Warm welcome to our respected Chief Guest, Geeta Bhaskar ma'am, on behalf of the KIMS Cuddles team, and to all the revered dignitaries who have gathered today for this breastfeeding week. Welcome, Dr. Sudhir sir, Regional Medical Director, HSV. So, we have gathered here today on the occasion of the World Breastfeeding Week. As most of you might be aware, the World Breastfeeding Week was instituted by WABA, which is World Alliance for Breastfeeding Action, and is celebrated every year between 1st and 7th of August to highlight the importance of breastfeeding in improving neonatal, child, and maternal health, and to establish breastfeeding as a natural way of feeding the infant, and to advocate for conducive policies and guidelines and programs for promoting the cause of exclusive breastfeeding. All international as well as national guidelines advise early initiation of breastfeeding within 1 hour of birth, continuation of exclusive breastfeeding for the first 6 months, followed by the introduction of age-appropriate complementary feeding, and continuation of breastfeeding until 2 years of age. Focus of this year's, that is 2024's World Breastfeeding Week, is towards breastfeeding mothers of all diverse groups of lactating women to reduce inequalities from baby's birth until 2 years, and concentrates on policies and program gaps leading to suboptimal breastfeeding by mothers. This year's theme envisages the crucial role of governments, healthcare facilities, families, employers, communities, and societies in protecting, promoting, and supporting the cause of exclusive breastfeeding. So we, as a team of pediatricians and neonatologists working in a corporate sector at KIMS Cuddles, Kondapur, we are among the first ones to care for the baby and mother at birth. So realizing the crucial importance that we as a team of healthcare providers play in supporting the cause of this very crucial healthcare intervention, we understand the importance of breastfeeding for both the baby and the mother, and are actively involved in promoting and supporting breastfeeding. So we have therefore endeavored this year, as in the previous years also, to take up activities to inform, to anchor, galvanize, and engage families, other healthcare providers, crucial stakeholders from the society, and collaborators to reduce inequalities and to support breastfeeding for all mothers in all situations, including emergencies, including crisis. So in addition to this activity today, which is a perinatal CME, realizing the importance of teamwork and partnership between the obstetricians and pediatricians in promoting this very crucial intervention, we also endeavor to have some other activities during this week between August 1 to 7, including the promotion of breastfeeding in some antenatal clinics, special emphasis on early initiation of breastfeeding in the first hour of life, irrespective of the type of delivery, discouraging the unnecessary use of formula. We also plan to have some other activities, including displaying breastfeeding material in the form of posters in the crucial healthcare areas in our hospital, engaging with doctors and nurses in various activities, including quiz, poster making competitions, and some public awareness interactions in the form of radio messages, TV shows, write-ups in local media, newspapers on this noble cause. So without much wastage in time, I would like to begin with the session. Rohini is the first speaker. Okay. So for moderating or chairing the first session, I hope we have been joined by Dr. K. Shilpi Reddy ma'am, Clinical Director of Obstetrics and Gynecology, and Dr. Chandrika ma'am, Senior Consultant Obstetrics Gynecology. Rohini, can you just call our two chairpersons? So for the first talk, we have a very dynamic obstetrician, Dr. Chandana. So she is going to talk to us about the crucial role of obstetricians in promoting breastfeeding awareness. So I welcome Dr. Chandana for the session. And Dr. Shilpi ma'am and Dr. Chandrika ma'am, I request both of you to kindly join us as chairpersons for the first session. Chandrika ma'am. So while Dr. Chandana loads her slides, may I request all the dignitaries to please step forward for the lamp lighting. Request the Chief Guest of Honor, Mrs. Geeta Bhaskar ma'am, eminent actor, artist, and mother herself, who has been a great breastfeeding enthusiast and who has honored us with her presence today. Welcome you, ma'am, and please request you to start with the honors of lighting the lamp. I also request Dr. Sudhi, Medical Director, to join us for the lamp lighting. Dr. K. Shilpi Reddy and Dr. Chandrika ma'am. So if the first speaker is ready, we would like to begin with the first session. So we all know the crucial role that is being played by the obstetrician in breastfeeding. So we are very fortunate that we have a very dynamic team of obstetricians in KIMS Cuddles who are very, very proactive in starting with early skin-to-skin contact and delayed cord clamping. And early skin-to-skin contact is one of the key interventions that has been found to translate into successful and exclusive breastfeeding from day 4, later at 4 weeks, at 4 months, and this continues into a successful sort of journey for the mother and the baby. So, in order to highlight and emphasize more on this crucial aspect, we invite Dr. Chandana. Dr. Chandana is MD OBG from JIPMER, and she is obviously from a very prestigious institution and a highly academic and a scientific person. And we are really delighted to call her upon for the first talk. It's also being run on Zoom. Screen share changes are important. Everything will screen will come out.
Good afternoon, everybody. Thank you so much for having me to KIMS team, Dr. Shilpi ma'am, Aparna, and all my dear friends and seniors. So this is not a topic which is not new to any of us, all the practicing obstetricians. But I'm just going to run through a few points which I feel are important in our daily practice. So we are celebrating the World Breastfeeding Week from August 1st to August 7th, and this year the theme is Closing the Gap and Breastfeeding Support for All. So we are in ideal position to assist women to make informed decision about feeding. And we need to offer them anticipatory guidance because most of the first time mothers, they have absolutely no clue how to go about breastfeeding and they start thinking only after delivery. Everybody has this misconception that it is a very natural process. It will happen as soon as the baby is born. But actually, we as obstetricians know that not everybody has such a smooth transition. A lot of bumps are ahead on the road, and some women are totally not prepared for that. So we need to educate them. And we need to support normal lactation and manage any arising breastfeeding problems. The WHO and all the international organizations strongly support breastfeeding. That is for obvious reasons because of the immunity power the breastfeeding gives and also a lot of other added value to the infant. And it is preferable to integrate care by the obstetrician, pediatrician, lactation consultant, and also involve the woman and the family members. Now, the ACOG recommends that all obstetricians develop and maintain knowledge and skills in guiding new mothers and physical assessment and support of normal breastfeeding and management of common lactation problems. In addition to this, practical skills, the obstetrician's responsibility and attitude also matters. Now, to be very honest, sometimes when we are busy, we see that we feel that we have a little less sensitivity. When the woman says, okay, I'm not able to feed, sometimes we may brush it off. I think we need to have a little bit more sensitivity when woman says that, and maybe if you are busy, come back to her later and then morally support and ask her what exactly is the issue and help her out. And if we are not able to be there and help her out, at least assign a lactation consultant and address the issue. Common reasons for discontinuation of breastfeeding could be a low supply, tiredness and fatigue, return to work, lack of family support, and introduction of formula feeding before 1 month, and obvious breast problems like infection and mastitis. And when healthcare providers are ill-equipped to manage breast issues, especially, mothers are more likely to resort to formula feeding. So in the antepartum period, at the first visit or in first trimester, the women should be sensitized about the benefits of breastfeeding. We need to take a history and identify any concerns like inverted nipples or any infections, any previous surgeries on the breast. They might have had a lumpectomy or excision of fibroadenoma. All these things have to be identified. We need to do a physical examination of the breast if possible. Most of the women I see they're more worried about the axillary lump which develops because of the accessory breast tissue. All we need to do is to assure them that it is a normal thing in some women. And we also need to talk about transmission of hepatitis B virus and HIV in women who are positive. Now, in the intrapartum, facilitating skin-to-skin contact between mother and infant and early initiation of breastfeeding are well-known measures. And this has to be started within 1 hour or immediately after delivery. Most of us, we put the baby on the mother's tummy in case of normal delivery after the delayed cord clamping. As long as the baby is vigorous, we can allow that to happen. Prolonged second stage of labor, maternal exhaustion, any complicated cesarean section, all these can delay lactogenesis. And during these times, the women need more emotional support and a positive outlook. Spontaneous vaginal delivery most of the time is associated with positive breastfeeding outcomes, but that necessarily does not mean all women who had a natural delivery will have no trouble with breastfeeding. And mother-friendly care, including non-pharmacological pain relief. We need to lessen opioid analgesics and resort to more massage and non-pharmacological methods so that presence of a partner, all these things will go a long way in initiating breastfeeding. Postpartum, kangaroo mother care is very important. We are of the idea that most of the time KMC is only the pediatrician's job. It happens in the NICU. But I think we should promote it on a daily basis in the wards also, and appropriate clothing. What I've noticed in the wards is most of these women have a nightie or a maxi which comes with a zip on either side. And I feel that doesn't give much of skin to skin contact. I've told a lot of women that you need to have a button down dress so that you can take the baby in and ensure maximum skin to skin contact. So appropriate clothing, and obstetricians can educate the women about the option of expressed breast milk. In case the woman is producing more milk than anticipated, she can express the breast milk or use a breast pump, and she needs to know how to store it and give it to the baby later. And nutrition to the mother. This is another one very important topic. I'm not going into details, but lot of Indian women have food fads. Most of them are not fed properly by their own family members because they feel that if you give this, baby will have more, baby may pass more stools, or baby may develop colic. They may be avoiding even normal routine foods. Sometimes I've seen mothers who are grossly dehydrated because they are of the opinion that if mother drinks more water, baby will get a cold. Lot of myths which need to be cleared. So whenever we visit the mothers in the ward, I think we need to tell them that which is a myth and which is a fact, and encourage them to take a good nutrition. And also the mother should watch for excessive weight loss in the baby. And in case there is excessive weight loss, more than 10% of the body weight, it needs to be investigated. These are just the breastfeeding positions. I've just included this slide to say that there is a football hold or rugby hold, which is very useful for cesarean mothers. In this, there is no pressure on the abdomen. So most of the women complain that they have stitch pain, they're not able to feed. So in such cases, we can tell them to use a pillow, keep the baby on the side, and then take the baby to the breast and feed. In the NICU, obstetricians can help mother make an informed decision and provide appropriate support. In case of preterm babies, mothers may need to pump the milk for feeding. So they need to have an appropriate breast pump. What kind of pump to use? What is the size of the cup? They're not very sure. So we need to educate them on these aspects. The other important thing what an obstetrician does is to address any breast issues, because very commonly we get cracked nipples, we get mastitis, we get women who are having breast abscess. So these issues need to be identified immediately and treated right away, because in case we do not treat them or the patient presents late, most of the time they have a very negative experience regarding breastfeeding. They are just of the opinion that it's paining, I don't want to feed. So that kind of negative experience sets in. And some of these women, they also have postpartum depression because they're not able to feed. They have pain, but at the same time, they're not able to feed, and slowly they go into depression. These things need to be identified and treated. Another common thing is engorgement. Most of the time before the mastitis sets in, the women complains of engorged breast. So we need to educate them and tell them to empty the breast regularly, pump, give breast massage and hot fomentation. If there is an abscess, we need to give appropriate antibiotics, and if required, incision and drainage procedure has to be done. Now, low milk supply, this can be either a real problem, or there can be a perception of low milk supply. The mother may think that she is not producing adequate milk. In fact, she may be producing, but she is not able to perceive it. In that case, we need to reassure her. If the feeding frequency is around 8 to 12 times a day, and the baby is gaining steady weight, and the baby is able to wet 6 to 8 diapers on an average, then we can just reassure her. In case there is a real weight loss in the baby, or the baby is lethargic or irritable, then we need to communicate to the pediatrician and take their opinion. Galactagogues, we advise Galactagogues most of the time, but they are very inconclusive because not all Galactagogues are very effective, and the response is also variable as we have seen in our practice. Most of the time, what we give is metoclopramide or domperidone. Rest of them all are Ayurvedic preparations, Lactare, Galact, so many things we give. But whether they really improve the breastfeeding or not, we're not sure. But moral support goes a long way. Patients with medical conditions like severe heart disease, NYHA class 1, class 2 can still go ahead and feed as long as there are no contraindications and the medical doctor says that they can continue breastfeeding. In case of severe NYHA class 4, they might be asked not to breastfeed, but then we need to always try to promote breastfeeding as long as there is no contraindication. Please go ahead and support these women. If there is a persistent palpable mass, it needs to be evaluated for breast cancer because nowadays breast cancer is on the rise. So it's not that uncommon to identify a breast lump which is a malignancy during the postpartum period. So we need to have a high index of suspicion and we need to investigate them appropriately. If it turns out to be an ordinary mass, everybody is happy. But in case if it is a real malignancy, then she needs to be referred to the appropriate person. And at the same time, when the woman is undergoing the evaluation and treatment, we need to support her. So the drive-home message is the influence of the obs-gynae cannot be underestimated, and this has to begin at the patient's first visit. Long before the mother takes the child to a pediatrician or the child health giver, she already has formulated ideas and opinions depending on what her mindset is and how she has interacted with her obstetrician. And these ideas are also based on the family and social influences. We can partially influence her choices and attitudes by encouraging breastfeeding. So we have an obligation to advocate breastfeeding. This will increase the chances for healthier mothers and healthier children. Thank you one and all for giving me this opportunity.
The session is now open for comments by the chairpersons and by the audience as well. Any questions, comments? You can just raise your hand. We'll bring the mic there. I'll first invite the chairpersons to share their comments.
Good evening, one and all. Sorry, good afternoon. It's not evening. Thank you, Chandana Madam. You have very detailedly covered all the topics. As an obstetrician, yes, we do have the responsibility. And I would ask my postgraduates, whenever you are examining an antenatal case, it is our responsibility to check the breasts also. And you should always identify the inverted nipples antenatally. This is the one thing which we keep on missing. Second thing is, 35 years is the, for peak age for breast cancer also. In my experience, I have detected 2 cases of breast malignancy during antenatal period when I was examining the breasts as a routine. That is point 2. Point 3, ma'am, I would like to, it's my query, because whenever there is a breast engorgement, it was an old school of thought that hot fermentation decreases the pain because of breast engorgement. But later on, I believe it's in 2008, it is cold ice pack. So that point actually I didn't see in your slide. So I just wanted to ask whether I'm wrong or something has changed. So it is ice. Okay, it is because, ma'am, I'm just pointing out because I wanted them to take a correct. So whenever there is a breast engorgement, always say to them that ice rakna hai. Okay? Thank you, ma'am.
Thank you so much, Dr. Chandra. It was an enlightening lecture. And then from my end, what I have seen these days is women lack upper body strength. Most of the time they are discontinuing lactation only because they can't carry the baby. They are saying that their arms are paining, their shoulder is paining, and literally they are discontinuing lactation for such silly reasons. Because for them, if there is no strength, it's like hell when you carry the baby for 20 minutes at a stretch. After 5 minutes to 10 minutes, they'll feel that pain, numbness, and everything, and then they have tears rolling down their eyes. So basically, to develop upper body strength is very, very important, and to make sure that they do their daily chores even during pregnancy is very, very important. Nowadays, with the luxury of maids and technology and mothers and mother-in-laws, they're not doing any activity. For that matter, they have already trained their muscles by doing only, laptop jobs. 90% of clients that we see here are those only. Hardly we see anybody who does, any other job. But then even women who are doing, who are homemakers and do household chores also, their household chores have got very much limited. And they have very less muscle strength, whether it is, your bicep strength, tricep strength, and your trapezius, strength and all that, that actually are very needed for carrying the baby for long hours and making sure that lactation is an ongoing process. This I have observed from a very long time, and to do activities that give you upper body strength is also very, very, very important. And that will help them to be motivated to give breast feeding. And another very important thing is cracking of nipples, dryness, and irritation, and some kind of discharges and all are very much anticipated. So I have a certain protocol that we give some breast cream and emollient so that their nipples, if they are flat, inverted, they are in normal size and shape by the time they deliver. So once the NT scan is done, routine advocacy of stretch mark cream and nipple care is also done at the same time so that they don't forget that point. And in our printed leaflet, we give that information so that whenever they have a glass, they'll at least not forget that yes, there is something to take care of, which has a later implication, which cannot be rectified after delivery. So after delivery, it's even more painful to take care of cracked nipples and inverted nipples. Sometimes our neonatologists have surprises. Sometimes walk-in patients come in and we deliver and we just have the patient is having flat nipples and inverted nipples. Mother is crying because she's not able to eat, and there is a component of postpartum depression that they add on if they are not able to feed the baby. They feel over guilty and undereducated at times. So it is our duty to make sure that things fall into place and make sure that the right information is given as a part and parcel of antenatal care. Thank you.
Very much, Dr. Chandana, for your lecture, and I'm going to request the chairpersons to please stay on for the next 3 lectures as well, because they are also relevant to both the obstetricians and the pediatricians. So we've had the first part wherein we spoke about the role of the obstetrician, antenatal care, antenatal education, early identification of nipple problems, breast examination during antenatal visits, soon after delivery, the role of early skin-to-skin contact, minimal separation or zero separation of the mother and the baby, delayed cord clamping, providing lot of reassurance, early identification of nipple issues, sore nipples, and providing lots of lactation support, being very liberal with early and frequent lactation consultations. That is something that we have believed and we have seen really helps. Spending a lot of time with the mothers. I think that's one thing which we all need to carry home as neonatologists and obstetricians. That's something we are always running short of, but this is something which we all need to do for our patients. The time that we spend hands-on with them, showing them how to latch, showing them how to hold the baby, how to position the baby, how to attach the baby. This goes a long way in empowering them with the right skills, with the right knowledge that is going to take them forward for continuing exclusive breastfeeding. Moving on to the next segment, we have 3 short talks wherein we have 2 obstetricians and 1 neonatologist from our team who are going to talk to us about some common issues that we may sometimes take for granted, but they may turn out to be significant barriers for breastfeeding. So for these 3 sessions, I'm going to introduce all the speakers in one go. The first speaker is Dr. Ankita. She is consultant obstetrician. and gynecologist from KIMS Cuddles team. She has done her MD-OBG from Nasik, and her special area of interest is laparoscopic surgeries. So she's one of our young and dynamic, the next gen obstetricians of KIMS Cuddles. We have for the second session Dr. Lakshmi Durga. She has qualified from Mumbai, and she is an expert in high risk obstetrics. So currently we have a 700-gram preterm baby who was delivered by Dr. Lakshmi Durga with who completely out of her efforts and her passion and her commitment, the baby has reached until this stage. Right now the baby is around 1100 grams and is coming out slowly. And for the third session, we have Dr. Arvinda Lochani. She is consultant neonatologist and pediatrician from our own KIMS Cuddles NICU team. She has done her DRNP in pediatrics, followed by fellowship in neonatology. And she is one of the most dynamic neonatologists in this part of the city, and she is very passionate about breastfeeding. So I'm going to invite them on to their sessions one by one. We'll begin with Dr. Ankita, and I request Dr. Shilpi ma'am and Dr. Chandrika to continue to chair this session as well.
So, hello everyone. I will be talking about the latching problems whichever nowadays all the young mothers are facing. So, one by one we will go. First of all, we want to talk about why latching and focusing on that problems are important for us. Because breastfed baby is the healthiest baby, and a happy mother is equals to a happy infant or a happy child. So, and we all know that breast milk is the best nutrition and immunity booster for each and every child. So, we have to focus that breastfeeding is to the optimum, best possible way, and how to achieve it through best latching this thing, practices, and we have to make sure that there is no problem with the mother or the child, and which ultimately leads to is going to affect the breast milk supply of the mother or breastfeeding. So, what is latching? It is basically the attachment of baby with the mother's breast. So, this picture shows how we should latch the baby. So, first of all, which majorly people, there's a, I would say, there's a problem which most of the people do is directly giving the nipple in baby's mouth. But we should always make sure whenever we start breastfeeding, whenever the baby is latching to the mother, this is the part, the chin. This part should be touched to the mother's areola. And before that, baby should be hugged or snugged as close as possible to the mother's body, and then the chin part of the baby should be touched with the lower part of the areola. When this happens, the baby will automatically open the mouth wide, and then we are supposed to put whole nipple along with the areola in the baby's mouth, because most of the lactiferous ducts in the breast are present in the areola. So until and unless baby is going to suck on the or put pressure on these ducts in the areola, milk letdown reflex is not going to happen. The milk will be less, baby will get angry because baby is hungry and baby is not getting any milk. So baby will become aggressive, leading to different problems like sore nipples and cracked nipples. So in fourth picture, we can see baby's mouth is wide open and whole of the nipple along with the areola is in baby's mouth. In fifth and sixth picture, we can see baby is making a peristaltic movement with his or her tongue, which helps in pressing the areola for milk letdown. Now, why it is important and why that important, I would say, why latching is important? Because it makes sure that milk supply is good, baby is fed properly, and milk supply is good, baby is fed properly, ultimately leading to happy and healthy child. As a result, the mother is also relaxed and giving a good breast milk supply. So this picture shows you can say improper latching. So in first picture you can see only the nipple part of the breast is inside baby's mouth. The areola is not in the mouth. So this is an ineffective latching and leading to aggressive nature or lot of pressure from baby's side from for sucking the milk, leading to painful or sore nipples. In the second picture, you can see the areola is also in baby's mouth, leading to effective latching and a pain-free breastfeeding experience. Now, what are the common latching issues which is happening? So first I will talk about the baby. For example, the tongue ties. That is one of the most common and underdiagnosed thing. Most of the times, baby had tongue tie and it is not diagnosed as a result, baby will have difficult in latching and ultimately breastfeeding. Oral thrush is like a fungal infection in baby's mouth, which can also irritate the baby and not letting baby feed properly or latch. Now, fussy baby. Fussy babies are the most difficult ones to be breastfed. So, whenever we have a fussy baby, or as a mother, if you have a fussy baby, make sure that you don't wait for baby to cry out of hunger. You make a schedule of 2 to 3 hours, and once the baby is hungry, your baby will definitely be hungry in 2 to 3 hours. Do not wait till the baby starts crying. Look for hunger cues and start feeding as per your schedule. Also, try to schedule the naps of the baby so that baby is completely slept well by the time you are going to breastfeed, and baby is fresh and active when you are trying to breastfeed the child. And you can also do that when you're starting to feed the baby. Express 2 or 3 drops of breast milk, apply it around the nipple, or you can also apply it around the baby's lips. So that will encourage baby to open the mouth and start breastfeeding. Another problem with the babies are premature babies. Premature babies are usually they are very small. Sometimes they are not strong enough to directly breastfeed from the mother, or sometimes they are very small and the mouth is very small to hold the areola along with the nipple to suck and get effective breast milk supply. So this happens with premature babies. What we can do is, initial days till the baby is not strong enough, we can go for expressing breast milk and feeding the baby. Now, from mother's side, what we can have is sore nipples. This is one of the complication of ineffective latching. Then large nipples. The mother can have a large nipple compared to baby's mouth, leading to all that baby will not be able to hold the areola along with the nipple, and baby will suck with lot of pressure and agitation. Now, mastitis, that is breast pain and infection, breast engorgement. If the breast is too full, then the nipple or the areola becomes too tight for the baby to suck and hold. So flat nipples or inverted nipples, like Dr. Chandrika already told, that we should be talking or we should be examining these problems very well ahead during our antenatal period. So if we are able to identify flat or inverted nipples during our antenatal period, we can start our treatment from there and then. We can ask our patient to apply a small amount of nipple creams and gently pull them throughout the pregnancy every day, at least once or twice. And if the babies you are already delivered and dealing with a flat nipple, then we can go for, there's a procedure known as syringing, in which we use a syringe, put it on the breast nipple, pull it gently just before breastfeeding. By this syringe, a small, we can get a small nipple, and eventually baby will be able to suck properly. Nowadays, we do have nipple pullers also available in the market. They are just like a small suction bulb with a cup. You put those cups on the nipple, create small suction gently. That will also pull the nipple out, and baby will be able to feed. But if ultimately all this fails, then nipple shield comes to the rescue. You can apply nipple shield directly on the nipple or areola, and let the baby breastfeed. But whenever you are using nipple shield, make sure that you are following the hygiene or hygiene properly, and sterilizing the nipple shield along with your bottles or whatever you're using. Low milk supply. Low milk supply can be because of multiple reasons. If the patient is or the mother is going through postpartum blues or postpartum depression, there is no enough, or mother is sick due to some other reason, or if there's no enough skin to skin contact, that can affect the breast milk supply negatively. If the mother is stressed due to any reason, that will also hinder the breast milk supply. Now, these are the certain breast feeding positions which we have already spoken about, so I'm not going to go in the details. Now, how to understand that yes, there's a latching issue, baby is not fed well. Or actually, this is also covered, but still, I will just talk in a bit. So, if baby is not actively asking for milk, is not demanding, or the number of feeds are less than 8 or more than 14 in 24 hours, if baby is starting to feed but going off to sleep or not continuously feeding for at least 10 minutes, then your breastfeeding is not sufficient or latching is the problem. If baby continues to suck for 40 minutes or more than that, then also latching can be problematic or the breastfeeding is not happening correct. Because baby is not getting enough milk, so baby might continue sucking or breastfeeding for a much longer time. If baby is not passing motion at least 3 to 4 times in 24 hours or not passing urine at least 6 to 8 times per day, that will tell us that baby is not adequately fed or hydrated. Or baby can be gassy, passing abnormal colored stool after first week of the delivery. In first week, it will be green. The meconium is green. So, from mothers, like I've already spoken, bruised or cracked nipples, sore nipples, these all happen because latching is not proper. Baby is sucking only on the nipple aggressively, which is a very, I would say, soft and uh, gentle part of the breast. You and mother can also see that even before she is starting to breastfeed, she cannot feel that the breast is completely full. So that shows the breast milk supply is less. So in between your two breastfeeding sessions, the breast should be completely full and no, I would not say engorged, but completely full before you start feeding. That means you have adequate amount of breast milk supply, and after the breast feeding is done, the breast should feel soft. So if this is not happening, that means either breast milk supply is less or the breast feeding is not happening properly. So how to avoid these issues? Like I said, we have to make a schedule. We can schedule for feeding every 2 to 3 hours. We can start and continue breastfeeding. Schedule baby's nap and always support the breast. This is important for somebody who has large breast or somebody like having a preterm baby, because the babies are very small. If you are not supporting your breast and if the breast is covering baby's nose, then also baby will not latch properly. Baby will get irritated because baby is not able to breathe and it is going to suffocate the baby. So always support the breast. You can make a C or U shaped grip on your own breast and hold the breast. So some feedings can take longer. That means it is not necessary that every time your child is going to breastfeed for 15 to 20 minutes. Sometimes, depending on the hunger and the milk supply, baby can feed for 30 minutes, anywhere between 15 to 30 minutes. And when your baby is breastfeeding, you can also help by massaging from upper to lower part towards the nipple while the baby is breastfeeding. This helps in pushing the milk towards the nipple or the areola and helping the baby to breastfeed properly. There's something known as delatching. So delatching is basically removing the baby from the breast. So usually this will happen naturally once the baby is, come done feeding, baby is full, not hungry anymore, or baby goes off to sleep. Baby will open the mouth naturally or spontaneously and leave the breast. But if baby is not leaving the breast, or if you want to remove the baby from the breast, always make sure that you are doing a proper delatch. By that I mean, first of all, release the suction between baby's mouth and your breast. If you directly pull the baby away, then it will happen that it will lead to nipple pull, ultimately leading to nipple injuries. So, with one, like in this picture, you can see you put one finger in the corner of the baby's mouth. That will help in releasing the suction, and then baby will leave the breast or nipple. Latch score. Basically, this is for the doctors or physicians or obstetricians who are dealing with the, children, newborns or the mothers. This tells us whether we will be able to support 7. So this has been shown that mothers who had latch score less than 2 on day 3, they tend to stop breastfeeding much more earlier than the mothers who had latch score more than 2. So what we are going to see in these score, first is latch on, that whether latching is properly or not. Second is A, audible swallowing. So we can hear the baby when the baby is sucking the breast, whether baby is swallowing the milk properly or not. This we can hear with different kinds of sound. Third is type of nipple, whether the mother has flat nipple, inverted nipple, or a normal nipple. Next is C. C for comfort, whether mother is comfortable while breastfeeding or not. Mother will continue breastfeeding for a much longer time only if she is comfortable. If she is uncomfortable because of sore nipples or any other health condition, it is more prone that she will discontinue after a certain period of time. Like Dr. Shilpi said, nowadays every female has lack of upper body strength. So if it is already explained that if I'm having arm pain, shoulder pains, then I tend to stop breastfeeding much earlier compared to somebody who is very comfortable while breastfeeding. Next is holding position. That how you are breastfeeding. Do you need any assistance? Are you able to do it on your own independently or not? So these things have to be looked by the obstetrician or neonatologist to confirm whether latching or breastfeeding will be able to continue for a longer period of time. That's it from my side. Thank you very much.
So we'll invite the next speaker, Dr. Lakshmi Durga. This right latch is one of the most important aspects for successful breastfeeding. You all would have seen while going for rounds, majority of mothers struggle with achieving the correct latch and hence end up with problems like sore nipple, cracks in the nipple, bleeding from the nipple, and all these may lead to premature cessation of breastfeeding or mixed feeding, eventually leading to postpartum depression and other issues, and then eventually the production synthesis of milk itself might get reduced because of the mother's stress and pain. So identifying latch issues and giving appropriate techniques for achieving the good latch can go a long way in improving the success of exclusive breastfeeding. And latch score is something that our lactation consultants routinely use. I have seen Dr. Vinoda mentioning the latch score every time she goes for a consult. She mentions the score. It not only gives us objective assessment of latch at one point of time, but also helps us to follow up whether it gets better or worse over time. So we'll now move on to the next segment on breast engorgement. Over to you, Dr. Lakshmi.
Yeah, good afternoon, everyone. And thank you, Aparna ma'am, for giving introduction. And for a small correction, it's long way to call me an expert. And thanks KIMS Cuddles neonatology team to make the baby survival for survival of the baby. I personally thank Dr. Aparna, Dr. Vamsi Krishna. I met them personally. So thank you both of you. So today my topic on the discussion is breast engorgement. So breast engorgement is usually due to the increased blood and lymph supply which occurs prior to the lactation. So this is the primary cause for the breast engorgement which occurs in everyone. And the second is due to the synthesis and storage of breast milk, which is a secondary cause. So this breast engorgement is more common in the initial days where the breast milk changes from colostrum to the mature milk. And it is more common in the primary para because these first pregnancy people, they take time to, start breastfeeding. So these engorgement changes are most common in the lower quadrant of the breast. So you can see there's a change in the shape and curvature of the nipple. And also the breast becomes inflexible, flat, hard and swollen. And the nipple is usually flat and inverted. So this is the toxic cycle of the breast engorgement, where the breast engorgement makes the nipple flat and inverted. So the baby will have a very shallow latch. And because of this shallow latch, the breast engorgement increases. So these are the causes of the breast engorgement. This is mainly for the postgraduate students. So primary breast engorgement is very common. It occurs in around 65 to 75% of the people. And this is due to the hormonal shift. So post-delivery, there's a decrease of progesterone and increase of prolactin, cortisol, and insulin. So these are the galactagogue hormones. Because of these hormones, they come and they replace the colostrum into the mature milk. So this occurs around the postoperative day 3 and day 4. So this sudden increase in the milk production and the baby may not take that amount of milk. So this will cause breast engorgement. But this is usually self-limiting condition because then baby and body will get used to the milk production and demand. So secondary breast engorgement is usually due to the mismatch between the milk production and milk removal. So it can be due to lactating mother causes or due to the baby or due to both. So the most common cause, usually the mother causes include hyperthyroidism. So hyperthyroidism mothers usually have more milk. And the second thing is pumping too frequently. Because these primary mothers, they were asked to breast pump between the two feeds and use of Galactagogues. I did see, I don't know, like Dr. Chandana mentioned that Galactagogues may not, work normally. But I personally saw some engorgement of breast. So pumping too frequently, use of Galactagogues, and in the baby it is due to breastfeeding difficulties like poor latch and poor positioning. So same Chandana ma'am mentioned, so many of you people, even me, like I'm also a post-cesarean mother. So during my first cesarean section, even I don't know about football hold. So I was asked to carry the baby, and there's a lot of pressure and a lot of pain on my sutures, so I couldn't do it. My initiation of the breast milk took me 1 week, and then one of my friends suggested football hold. See, I'm my gynecologist, I still don't know. So once I got to know about the football hold, and I didn't look back. So education is very important. And third one is that last one is there will be decreased infant feeding, like during sickness or due to cracked nipple, even mother will be frightened to, breastfeed, or when the baby sleeps for prolonged time at night. So this all causes decreased infant feeding. And what are the signs? So signs are usually breast will feed hard, tender, tight, swollen, warm, and all these things. And nipples are usually flat or inverted, and veins becomes more prominent due to venous congestion, and low-grade fever can be seen. So what are the complications? Complications are blocked ducts, mastitis, and breast abscess. So why maternal education is very important? Because in the village areas, if you see, having hard breast, they feel that they have more milk. So they try to retain that hard breast. So they don't know that between two feedings, the breast should feel soft. So they're not educated properly. So this education is very important because if this breast engorgement is not relieved, it can lead to blocked ducts, mastitis, breast abscess. So what are the treatment? Usually analgesics, so ibuprofen and paracetamol usually relieve. And like Chandrika ma'am mentioned, it is cold packs to reduce inflammation, wearing supportive bra, manual expression or using of breast pump, both electrical and manual breast pumps work, and breastfeeding more frequently. And there is, I heard this scheduled feeding. So what is this scheduled feeding? Like you feed once in 2 hours because you don't want the baby to wake up early, or like it's like what you can say, um, timetable to the baby. So once in every 2 3 hours. So once in every 2 3 hours, like avoiding the scheduled feeding will decrease the chances of breast engorgement. Oxytocin helps in expression of the milk, and anti-inflammatory like serapeptase or protease. And this is a new one, which I also came to know now, which is manual lymphatic drainage. So according to the picture, if you see, with this manual lymphatic drainage, we are increasing the lymphatic flow in the breast. So there are 3 steps for this. First, we'll try to pull the breast up, so it will release the tension. And once it is pulled up, above the clavicle and in the axilla, these are the 2 places where lymph nodes are present. So we do small circles, around 10 circles in the supraclavicular area and 10 circles in the axilla. So this will enhance the lymphatic circulation and decreases the engorgement and venous congestion. And then you will do upward movements from the nipple towards the axilla and towards the clavicle. So this helps in lymphatic drainage. And this is the first method. And second method is reverse pressure softening. Means we are giving pressure from outside. So how does it act? So like I told you, these breast engorgement may cause flattened or inverted nipples. So if at all we are giving pressure from outside, the condition may decrease, the nipple condition will decrease, and it will around the areola, and this moves the fluid away from the nipple and allow the baby to latch forward. So there are 3 methods in this. First one is two-handed one-step method. Like we give two hands, we press nipple from all the sides and hold it for 3 minutes. So automatically contraction will decrease. So this is only one step. And second one is two-handed two-step method. So we keep two fingers on either side of the breast and we press from sides. This is one step and hold for 3 minutes. And then we press from above and below. This is the second step and you hold for 3 minutes. Okay, last one is one-handed flower fold. So you make a curving of the fingers and push the fluid away from the nipple and hold for 1 to 3 minutes. So this all will release the congestion of the nipple. They make the nipple to protrude out as pointed out, and the baby latch will be good. And when baby latch becomes good, automatically the engorgement decreases. And this is still under trial. I don't know. I heard this breastfeeding lactation consultant is Dr. Vinoda. So I don't know whether she used this method or not. So I never used. I don't know any of you used or not. So it is cabbage method. It was okay. Even on the legs. Okay, so this is new to me. So this is a cabbage treatment method. So you take two cabbage leaves, you wash them, you remove the excess water, you will cover around the breast, but you leave the nipple exposed. So the nipple is exposed. And then you wear the bra over that. So this will keep the cabbage leaves in position. And then this is for 20 minutes. So you can be that 3 times a day. And so the results of the engorgement decreases. Oh, well, not a cabbage treatment. Okay, yeah. Okay, okay. This cabbage, mm, no one is cabbage method. We use, yeah, okay. Okay, okay, okay. So nice to hear. So I'll also start using it. So these are the final steps, how to treat the breast engorgement. So usually you use warm compress or warm bath, like Dr. Chetika ma'am mentioned. So this is to increase the milk letdown. So this is before the feeding, and you have to feed more regularly, at least every 1 to 3 hours. Don't follow any scheduled feeding, and nurse baby as long as the baby is hungry. And next, massaging your breast while nursing. So these massage, as Dr. Ankita already told you, is towards the nipple to increase the breast secretion. And between feedings, apply cold press. So it is cold press between feedings, and before feeding, it is warm press. So how do you prevent? So as I told you, it's always about breast feeding education in the antenatal period. So always start with it because so many mothers, be it doctors are more apprehensive of feed. So everyone, so many of us don't know how to feed. They're worried about the position. And to be frank, I don't know, sometimes we overdiagnose flat or inverted nipple. I have seen so many people overdiagnose it, and then mothers have become really apprehensive. But I feel that once the baby sucks, it is more better than the syringe. You know, baby forms the nipple more better than the syringe. I feel it personally, nothing else. So it's about all about education. So education should start early in antenatal period. At least they should have 1 or 2 classes, and then breastfeed more frequently, around every 8 to 12 times in 24 hours. And baby snatch, Dr. Ankita already told you. And good positioning is important. Massage between the feeding and during the feeding. These both are important. And don't limit baby's time breastfeeding. Avoid excessive breast pumping. So once you get good amount of milk, you don't need to store in the freezer. So okay, the freezer storing or more breast pumping is only to enhance and avoid any prelactal feeds or formula feeding in between. So the moment baby cries, it's always about feeding. No. So baby will cry due to different reasons. It can be due to wet diaper. It can be due to mosquito bite. Just like baby is born. So it's not always about feeding. So mothers are more apprehensive about the baby cry. So they always think it's due to the decreased feeding needs. So then gynecologists over prescribe the Galactagogues. No need. Judicious use of Galactagogues. So what is the impact of education intervention? This is a study on this.
So the people who are educated regarding breastfeeding education during this antenatal period, they have reduced the chance of breast engorgement at postpartum 3 and 4 because they started feeding early, 30 years. And they have prolonged the chances of exclusive breastfeeding because they don't go into depression that I am getting less milk. The most common cause of stopping the breastfeeding postpartum is because mother thinks that she is supplying less milk. So the moment she feels that, she keeps on bottle feeding and it always shifts towards that side. So all mothers should have support in that manner. And, so this combination of knowledge and skill-based education has been beneficial for sustaining exclusive breastfeeding by mothers. Thanks for giving me this opportunity. So, good afternoon, everyone. My topic for today is nipple pain. So, my previous speakers, Dr. Ankita and Dr. Lakshmi Dukka ma'am, they have spoken about the different latching and engorgement and related issues. So, when you go for the postnatal rounds, usually the mothers complain of the pain. So, the nipple pain, like the reason for it is different during the different days of the postpartum period. So, we'll go through it one by one. So, like pain-free and effective breastfeeding is important for the successful lactation and also for nutrition and overall development of the baby. And it should be a satisfying experience for both the mother and the baby. So, persistent nipple pain is one of the common complaints of the mother when they visit in the postpartum, like OPD visits or when we go for the rounds. So, the pain, like we should think of in both the maternal aspect as well as in the baby aspect. The most common thing is the latch related issue. So, whenever you see a mother who is complaining of pain in the first 2 days of life, you assess for the latch of the baby because that is the most common cause of the pain. And 30% of these mothers, they seek the professional support. Rest of them just bear through that pain. So baby related issues, latch issues, shallow latch and any palate related issues. And these are the causes from the baby side. Maternal side, in the first 2 days, decreased blood supply and decreased milk supply, sorry. And after the first few days, engorgement and overproduction of the milk and filling of the areola with the milk and blocked ducts, these are the common causes in the later on period. So this can ineffective latching also causes sore nipples, nipple cracks, and milk blisters also. And if there is a persistent pain throughout the time of lactating the baby, then you have to think of other infections like fungal infections of the breast and oral thrush also should be looked for the baby. Rare causes like Raynaud's phenomenon should be kept in mind, but this is a rare possibility. So, depending upon the timing of the pain, when the baby is latching on the breast or while the baby is feeding at the mother's breast or when the baby is coming off the breast, so we can divide like that and see for the issues. When the pain starts when the baby is trying to latch on, so it might be either a cracked nipple or poor latch. The mechanism of latch has been already explained. So we should look for the signs of good latching, like the baby's mouth being wide open, lower lip turned outwards, and the baby being towards the mother with baby's abdomen and mother's abdomen touching each other, and the baby is taking slow and deep sucks with pause in between. And whenever the latching issue is identified, we can advise the mother regarding the proper latching technique and try different methods of breastfeeding like cradle hold and cross cradle hold, which our lactation counselors generally explain during the rounds. So in the initial 2 days, there may be a slow letdown of milk that causes the baby to suck more frantically and also causes the pain for the mother. So before embarking on the breastfeeding, the mother can massage her breast and then slowly try to improve the blood supply so that the milk will start flowing as soon as the baby tries to latch on. So insufficient milk supply and nipple pain can also lead to the feedback inhibition of the milk ejection reflex due to this pain. So we should try to avoid that by ensuring the proper latch earlier on and advising the mother regarding the care that need to be taken before starting the feeding. So when the pain is there throughout the feeding and it stops when the baby comes out, you should look for the shallow latch, that baby not latching deeply enough and sucking only at the nipple, which will not result in the effective transfer of milk from the mother's areola to the baby. So initially when we teach them, they might be latching correctly only, then slowly the baby may be coming out and sucking only the nipple. Most of the mothers, like, they need proper education right from the antenatal period itself. They'll be tired postnatally. First day they'll be sleepy. Baby will also be sleepy. Then they'll not be giving proper feeds. So we should emphasize then, wake the baby every 2 hourly and try to feed the baby so that they will not fall into that, like the baby losing excessive weight and giving formula. And then when the mother starts having engorgement, the baby will be already adapted to the bottle. So this happens like when the baby goes on to bottle feeding, the technique of feeding from the bottle will be different compared to the direct feeding from the breast. Then also the mother might develop the pain because of the tongue movement of the baby, which mechanism will be different, and the mother will have pain during the feeding. So we should also check for oral thrush and any tongue tie for the baby and correct those issues accordingly if they are there. And pain as the baby finishes. So like most of the mothers, they don't know, like primary mothers especially, second gravida mothers, they know, like a baby should not be roughly pulled off from the breast and the baby should be allowed to suck as much as he or she wants. And then once the baby finishes, then slowly the suction needs to be released and the baby taken off the breast. That also causes the nipple pain. So we have to identify the early feeding cues of the baby and not wait until the baby becomes frantic and starts crying. So the early cues being the baby starts stirring and opens the mouth and looks towards the side, which indicates the rooting reflex that the baby is looking for the mother's milk. So at this stage itself, if the mother starts feeding the baby, then it would avoid all these problems. The second stage being baby starts stretching and moving a lot and puts the hand to the mouth. This we see most often in the rounds. The baby will be doing all these things, but still the mother might be tired and she doesn't realize that it is time to feed the baby. So when we are going for the rounds, it's better to assess this latch score and also the feeding cues to the mother so that she will be able to feed the baby effectively. So late cues are when baby will start crying, and at this time, even if the mother tries, the baby may not be able to latch properly and become agitated and takes time to calm down. So these are the different positions which you have already seen. So different positions also help the mother to hold the baby. For cesarean section mothers, they advise this football hold and cradle, cross cradle. These are the commonly used positions. Side lying and laid back positions also can be used based on the maternal comfort. So this the latch score has already been talked upon. One thing which I would like to emphasize again, which Dr. Ankita explained in detail, is it's good to have like a latch score at different periods of time, so that we also know if the mother's comfort is increasing or not. So we can have our postgraduate students to look for and assess objectively, like the latch score, if the mother's comfort level is increasing or not. So once we give them that confidence and they start the breastfeeding, then there's no looking back for them. They can feed successfully for a longer period. So that initial 4-5 days is the time period when they need the maximum support. So throughout the pain throughout the time of breastfeeding, continuous pain, two causes we should keep in mind. So vasospasm, this leads to the constriction of the blood vessels. So the conditions which cause this are sore nipples, stress, medical conditions pre-existing like autoimmune conditions like lupus, rheumatoid arthritis, thyroid dysfunction. These are the common conditions, and we should also inquire about maternal smoking and any use of beta blockers. So mother should be free of pain and stress. That does not cause this vasospasm. that Dr. Shilpi ma'am always emphasizes by encouraging them to do yoga and all those things for relaxation. So this is very important actually. Mother should not be feeling stressed in the postpartum period. And simultaneously, we should check for the thrush in the oral mucosa of the baby and also the maternal skin areola and treat with topical antifungals both for the mother and the baby. So that is the cause for continuous pain. And when the mother complains of the pain in the nipple, we should actually see the type of the nipple, whether it is normal and baby attaching properly or not. This is the first thing. And if they are using the breast pumps, the suction of the breast pump, how much pressure they are applying, and whether the pump is being gently removed from the nipple or not, also we should see and assess. Then if there is a flat nipple, then the negative pressure with the help of a syringe should be taught to the mothers, and then train the baby to latch on this type of nipple can be tried. And engorgement, madam spoke in detail, so we should watch for the signs of engorgement. They having tenderness and pain over the breast, and tell them effective ways to relieve the engorgement. And reverse pressure softening should also be trained to the mothers whenever they complain of these engorgement issues. Gentle massage and hand expression also can help when the mother is having the engorgement issues. Then flat nipples we already spoke of, and because of this improper latch, if they develop the soreness or cracking of the nipples, the mother can apply her own expressed hind milk to that cracked part, which will help in healing, or lanolin based ointments also can be applied. And if sometimes they wear too tight inner wears, that leads to the dryness and itching of the nipple area. So then we should advise for the appropriate sized bras for the mother, and also avoid heavy detergent, and wash them gently and change frequently. She should wear the loose fitting clothes basically. And then if the pain is persistent, we should look for the signs of mastitis and breast abscess also, and treat them accordingly. So these are the signs that the symptoms and signs which the mother will tell. Her breast feels hot and tender and painful. General feeling of tiredness also will be there for the mother, and if she is having fever, we should treat the mother appropriately. So, but the most common issues are the latch related issues that lead to the nipple pain. And secondarily, the nipple cracks also mothers generally complain of. Based on the timing of the pain, earlier is less milk related issues, and later on engorgement related pain should be looked for. And any other anatomical conditions for the baby like high arched palate, and preterm baby means the latching might not be that effective. And shallow latch issue should be looked for and treated accordingly. So the take-home messages of my topic are, so we like as doctors, like if we become mothers also, like some of the issues we may not know. So as mothers, their focus will be till the time of delivery of the baby. Then they become so tired in the first 1 or 2 days. So we should educate them antenatally, antenatal lactation sessions, start early skin to skin contact, and the frequent breastfeeding, and looking for the lactation issues periodically during the postnatal rounds. So we'll help the mothers continue the breastfeeding for longer periods. Thank you.
Thank you, Dr. Arvinda. Uh, Madam, with your permission, to my postgraduates, uh, for August 1st to August 7th, we celebrate it as a breastfeeding week, right? Now, covered all the topics regarding latch and the breastfeeding techniques, right? You understood, I believe you understood what was spoken in the talks. Now, I would like to ask you, what is the commonest cause of lactation failure? This is an undergraduate question. What is a, yes, psychological stress? It is a psychological stress, and as an obstetrician, as well as those who perform the nursing duties. Because I have worked in the peripheries, I have worked in the medical college for last 15 years, I have seen the nurses are much closer to the patient rather than a treating physician or a obstetrician. they let all their, problems, they speak about all their problems only with the nursing staff. So we should emphasize to all the patients that there will always be challenges. I myself am an example where for my first child, I could not feed for more than 2 months. I was in army and we were not given for more than 2 months of leave after giving birth. And after second month, you will not believe, every day I used to have a stress, today I would be able to go back and feed my child or not. So eventually in 15 days, my lactation suppressed on its own. I tried all my best I could, but I could not. Eventually, when I did my post-graduation, I went and asked my senior consultant, Brigadier Katpalia, telling, sir, even Sri Lankan Army, the women have got 6 months of leave postpartum. How come in India we are having just 2 months? And after my question, there was of course, it was not because of me, but there was a talk between all the senior consultants, gynecologists, Indian Army, and in 2010, they made a reform of 6 months of maternity leave for the women in Indian Army. That was one. It's not because of me, but they made it. At least they made it because I was an example of lactation failure because of a psychological stress I faced. Immediately after 2 months, my lactation suppressed. So you all should make an effort to speak to a patient that there will always be a challenges in life. You should not let go of the feeding. Second thing, uh, why we should encourage breastfeeding is because it is natural and sustainable. There is a zero waste. There is a reduced carbon footprint. There would be healthier outcomes, water conservation, and economic benefits. Of course, all these words I carried from Shilpi Madam. I never used these words before. Okay, thank you all.
So I thank all the three speakers for making the previous session lively and the moderators, Dr. K. Shilpi Reddy ma'am and Dr. Chandrika ma'am for your valuable insights. So we'll now carry forward with the program. We have a debate, a very interesting debate on Galactagogues, whether it is a boon or a bane, followed by the last session, which is a panel discussion, which is going to give us practical insights about the everyday challenges that we all face and we all need to tackle as pediatricians and obstetricians. But before we move on with the scientific program, it's my privilege to now call upon our chief guest, uh, Geeta Bhaskar ma'am, who is not only a prolific actress and artist, she's a mother herself, and she takes great pride in sharing her breastfeeding journey today. So, with a great round of applause from all of you, I welcome Geeta Bhaskar ma'am to the dais.
A very good afternoon to all of you. Namaste, Ali. I think you all had almost, a very, what to say, a very professional lecture and about all the technical terms and everything. And I'm going to give you just a filler of my experiences. I don't know much of all these technicalities, but then I would love to share my experiences because it was not that easy for me also. And maybe you can take home something with your practices that you'll go ahead with your scientific approaches. Um, my marriage itself was a little late, of course, then. Now, of course, people are getting married after 35, 42. But then in those days, it was too much for me. I was 30 when I had my child. And, and it wasn't an easy journey for me at all. Ma'am, you must give me some time, right? Let me give me my, I've got a podium, I've got the mic, let me speak. Uh, and I have an audience of all educated doctors over here, and my request is that we go a little more, personal with your patients, please. Uh, because when I got married, let me just go before this breastfeeding. I would like to give a little of my experiences as a mother. My husband was very insistent that I do not do a job and concentrate only on my son. He said, son. He was very positive. He said, yes, and I will get a son. I will marry a girl. I will marry a girl who puts mugu on the streets, and everybody used to laugh. It seems that ee kalamlo evarra dortaru muggese ekkada unnaru, and I think all that positive feelings also come in. So some affirmations. So of course, I was also into the practice of that because my grandfather was very, very insistent. I was very obese, and my grandfather said, "Illu udchi tudu muggulei." It's wonderful exercise. When ma'am was telling about, the strength of this, yes, my mother never believed in the grinder, in the mixie and all that. We did have mixie in the house, but then she would, make me grind because I was the fattest and they thought I had all the strength. And thanks to all of them, thanks to all of them. And, that gave me a lot of mother strength. And it also gave me a lot of strength, emotional strength also, I think, for all that I went through my marriage. Um, after then, my husband said, I will get a son, I will put him in HPS. No, Madhuraku, you don't come in between, come in the way. And of course, there was no, there were no tests or anything. Of course, those days we did have x-rays and all that. And my doctor was Kalpana Alexander, a wonderful doctor who also emotionally connected to me and spoke to me so well each time I visited. And, in the third month, you won't believe, in the third month, as I was going down to put the mugu, we were on the first floor, 3 steps and I fell down. I rolled down. And, and nobody saw me, but for Mr. Hari, he's in the task force now. He holds a very high position there. I sent a message to him also that I'm speaking on this. And he said, no, nothing will happen. I am having a son, nothing will happen. I said, you got married only to have a son, not to look into your wife. That was the thing. And then after that, of course, nothing happened. I went through the whole process of pregnancy. Again, it wasn't a very smooth ride for me because I had nausea till my child was born. I had, from the beginning, I had severe nausea, and all that I could take was only rice. The previous day would pour water, put some salt, and I had that. I only had that, and the fears that everybody gave me around, my next door aunties and all of them, they gave me a lot of fears, saying that your child's brain is not going to grow. You are not eating anything. You have to eat something, and even the smell of something would just make me puke. And I couldn't, I would just close my nose and mouth and then cook something and then go away into the bedroom, sleep for some time. And of course, I would also watch some TV programs. That was, in those days, it was only a few channels, and I would take to dance and music only. And probably that also helped a lot for my son. And, uh, and then after that, it was only that so many people instilled a lot of fears in me, but then I think I was strong enough to say that yes, probably I took a little positivity from my husband saying that yes, I'm having a son and he's going to have everything right. Nothing is going to happen. I'm going to have a very good child. That was the affirmation I gave myself every day. And after confinement, of course, after confinement, it, it was breastfeeding, and my mother took me away because I went just 9 months, 9 days before confinement to Chennai. I was born and brought up in Chennai, so my hometown was Chennai. There at Maternity Hospital, the doctor was very angry with me because I was too weak and I was doing a lot of work. I was doing all the work, and we had 2 dogs also to attend. So with my pregnancy, I went through all the household chores, took care of myself also at the same time. And of course, I had a child who was just 2.7 normal Indian weight child. And then after that, my mother said, I'm going to have you for 3 months. I'm not going to send you. And there comes the breastfeeding. From there, she said, she fed me a lot. She fed me a lot, and I became very fat again. All the weight that I lost I was gaining a lot of weight almost every day. She fed me on bread, and we are non-vegetarians. That Sora Chapa, shark, Pal Sora, I think. So that was also very good for milk. And it's a very rich source of calcium. So she said that. And then oats. That was my main meal, like other than the vegetables and other things. So she said, at least let him get a lot of nutrition through milk, because I couldn't eat anything properly when I was pregnant. So I think that also should go into your teachings to the patients, that milk is very, very important. Mother's milk is very important. And my husband insisted that I give milk for 2 years at least. He just said, no dabba, nothing. Nothing was given. Nothing was given. And I was always consulting my doctor. And she said, no, you're all right. You're healthy. You can give. And she was checking on me also. And after 2 years, she said, no, Geeta, you have to start giving some supplements too, because you don't know how much of milk is going to the child. So, of course, as I was watching and, listening to your explanations, like when the child, you know that the child is full, isn't it? When the child is sucking, yes, milk is going on. I was observing that too. And as I was feeding, when I was feeding, I went through a lot of emotions too, because there were a lot of other things that did affect me, coming from a political family and a family where, I do have doctors. My sister and my sister, a dietitian from Jipma, and my brother-in-law and many of them as doctors, they would say that don't tie the cloth around after the childbirth. And my mother-in-law, see, there are these emotional upsets also going through as stress for the mother, where the mother says something, the mother-in-law says something, you follow our rules, you follow our rules. I think you'll have to have a counselor too, please. You must have you must be having, but this should go into into a little more intricate sessions, I feel. The mother, we would have some practices, they would have some practices. So when they come, they would say, no, the child is swallowing a lot of air. Nee kadupu kuda inta ubbipotadi, you will become very, very obese, galipotadi and all. Again, I consulted my doctor, and she said, no, that is a conventional way, and you can go through it. You can do that also, satisfy them if you want to. But then there are ways where you can also, treat yourself that air that goes inside. She taught me a few vaginal exercises, and then, of course, I was doing my daily course also, so that also helped me a lot. And I think my son, he became healthy, and I was also fat, to the extent that one of my sisters-in-law said, see, this is father's shirt, this is my Anna's shirt, or this is my Odina's blouse. So that was the weight I put on. I didn't bother again. Um, I think I was strong enough to take all that, because I was always looking upon my son and how would he grow and what he should be like. As I was feeding, I was listening to a lot of music, I said, and I was doing crossword, because crossword is my an addiction to me, like. So I kept doing all that, and I was, keeping myself a little free from all the other stresses that I had. I would divert myself, and then after the period, after the 2 years, slowly I started giving straight away rice. There was no Farex or anything for him, but frankly speaking, we couldn't afford it also, and I used to give him some, the traditional kanji, like with all the millets and everything. Now people are eating millets, and those days my mother would just roast everything and give it as a powder, as a porridge, which I would start giving, which I started giving my son, and of course a little of dal and rice and vegetables and everything. So that was my experience with my child, and I hope you all take in a little and, please let there be a lot more counseling sessions of, examples of people who have gone through stress and everything and how to manage it, because we are not giving the child to the family, we are giving the child to the society. So that is what I feel, and I keep telling everyone the same. I do go for life skills programs where I meet youngsters. I think youngsters should be given a lot of training first before they get into, the marital bliss. And then after that, if you want a child, you have to give in something. You just can't have everything all the time. If you want a child, you have to give in a little. You just can't take it for granted. So that is what I feel. And then I do connect to a lot of children with my art education. So people, you introduced me as an actress. I was first an art teacher. At 58, I became an actor. But then I have more than 35 years of experience as an art educator, and I'm still going around schools with my art course that I have developed, and many schools are taking it up. I do connect to a lot of children who come up and tell me so many things. They are so emotional. They have a lot of stress that is going on in the family. I think it all depends on how the mother trains with during pregnancy, during breastfeeding, a little, at least 20-25% of that goes into the upbringing of a child. So thank you so much for giving me this opportunity. Thank you, and happy, I should congratulate you on the 10th anniversary, and thank you, Ms. Dr. Vinodini, for bringing me here onto this podium to speak, and Dr. Aparna also for, keeping in queue all the other formalities. Thank you so much.
Thank you, ma'am. I think it was a very heartfelt and a very personal sort of expression of your own breastfeeding journey. I think being a celebrity, an artist, and an actor yourself, and mom to a director and a filmmaker, I think it takes a lot of sort of courage and kindness to bring forward this very sort of personalized journey and share it with everyone, and to demystify a lot of challenges that mothers normally face, and emphasizing how all of us as healthcare providers must take out time from our busy practice to address these concerns as well. In addition to the medical aspects, in addition to talking about labs, talking about early skin to skin contact, it also needs a couple of additional minutes of time and a little bit of extra effort for us to go that further distance up and try to address all these innumerable kind of challenges and complexities all mothers go through in their first few days of their breastfeeding journey. I think it is wonderful that it comes from a celebrity personality such as you. When it comes up from someone like you, it makes it all the more sort of heard and visible, so that we never forget these small and simple messages when we go out for rounds every day. Before I go on further, it's also my duty to thank our sponsors for the day. I'd like to thank Zydus, especially Mr. Jagdishwar and his team for putting up this wonderful program and making it possible for us to actually host, all doctors and obstetricians, pediatricians, and nurses on this wonderful occasion. Thank you, Zydus, and thank you, Jagdishwar. They are here to talk about one of their important products, which is about prevention of flu, which is important not only in children but also in pregnant women. Thank you, Zydus, for the event. And before we move on to the next event, which is the debate, it is our privilege to thank and facilitate our chief guest for the day, Geeta Bhaskar ma'am. So I request ma'am to please take the chair of the dais, please. So I'm first going to request, on behalf of our team from KIMS Cuddles, Dr. K. Shilpi Reddy and Dr. Chandrika ma'am, to kindly garland ma'am with a shawl box.
Of Pediatrics, and it's a pleasure for us to hear your wonderful journey. And a message now which I will add to whatever I tell my patients. Why should I breastfeed for 2 years or beyond? Because Madam has done it and has given us a wonderful director and actor. So if you want your son or daughter to be excellent in whichever field they choose in, please breastfeed for 2 years and beyond, and please breastfeed immediately after birth. And this is a small token of appreciation, ma'am. You have been a champion of breastfeeding, and this is a small gift from us to you.
Krishna, and thank you so much, ma'am. So we proceed now with the rest of the scientific sessions. We are running late, so we'll have to hurry up with probably the next two sessions. We next have a very interesting debate on Galactagogues. Are they a boon or are they a bane? I request the audience to please stay back because these sessions are not only interesting but they're also useful for your exams. So to talk for and against Galactagogues, we have two interesting speakers. Dr. Amrita, who is a consultant obstetrician, who was earlier associated with our team here at KIMS Cuddles, and now she runs her own nursing home at Kadimi Nursing Home, is going to talk in favor of Galactagogues. And to talk against Galactagogues, fighting against an obstetrician is not easy. And we have a very courageous neonatologist who has endeavored to do this. Dr. Vamshi Krishna is going to talk against Galactagogues. And I'm going to request both the speakers to sort of limit your time to maybe 7-8 minutes so that we can wind up by 15 minutes from now and probably have panel over the next 20 minutes. Thank you.
Good afternoon, everyone. I'm Dr. Amrita. Today I'm here to speak. Firstly, thank you, Dr. Aparna, and to the KIMS team for giving me this opportunity to talk. And today I'm going to talk about the role of Galactagogues, if it is a boon or not. Okay. So uh, the Galactagogues are the substances which are used to improve breastfeeding. So let us know what is the most common reason for early discontinuation of breastfeeding. It is inadequate breast milk supply. So when all the non-pharmacological lactation support strategies have been exhausted, like giving confidence to the mother first, counseling her, or teaching proper latching techniques, and giving support, giving her privacy, and all that, and giving encouragement, teaching regular feeding, complete emptying of breast, all those things. After all that is done, and still the patient is not able to breastfeed properly, we can, to some extent, use pharmacological galactagogues to augment lactation. How much they are useful or not, that we will know now, but we can educate. So the galactagogues exert their pharmacological effects through altering the hormonal milieu, especially affecting the prolactin and oxytocin. So these are the pharmacological galactagogues we will be discussing in the talk today, and we will come to them in some time. So firstly, why do we want to improve the breastfeeding? Why do we want to stress so much on breast milk? Because breast milk is easily digestible, of ideal composition, available at the right temperature, at the right time, and free of any bacterial contamination. All of us know this, that all of us know the advantages of breastfeeding for the infant and the mother. For the infant, it decreases the incidence of diarrhea, allergia, otitis media, pneumonia, UTI, and necrotizing enterocolitis and all that. In preterm and low birth weight infants, it was found that for every 10 ml per kg per day increase in ingestion of mother's milk, rehospitalization was reduced by 5%. So also in another study, it was found that predominant breastfeeding for the first 28 days of life gave better IQ, better academic achievement, working memory to the infants in various preterm enzymes. Then for the mother, what are the advantages of breastfeeding for the mother? Definitely it is very convenient, economical, and emotionally satisfying. The bond is built between the mother and child. It helps to contract the uterus and decrease the maternal blood loss, and it promotes the infant, mother-infant bonding, and increases the self-confidence of taking care of the child. Then ovulatory cycles are delayed, so it helps in contraception also. Then also it protects against breast, endometrial, and ovarian cancers. So let us know a little bit about physiology of lactation. I'm sure all of you know this. So in an intact hypothalamic pituitary axis is very essential to maintain lactation, initiate and maintain lactation. Lactation has 3 stages, as we know: mammogenesis, lactogenesis, galactopoiesis. So in mammogenesis, mainly mammary growth and development. So it is a multi-hormonal thing, the breast milk production. So in mammogenesis, uh, mainly estrogen and progesterone play an important role in development of the breast tissue. And prolactin also forms the breast milk, but then it is under the negative feedback of estrogen and progesterone, so it does not, milk is not ejected immediately. But at delivery, the progesterone drops down and the negative feedback is released, so prolactin functioning, there is increase in prolactin level and breast milk is ejected. Galactopoiesis, as we know, is maintenance of lactation. Here, the gonadal hormone should be met for the proper functioning prolactin, and suckling definitely promotes the release of oxytocin and prolactin, thus maintaining lactation. So oxytocin, as we know, is very important for milk ejection because it causes contraction of the myoepithelial cells. So what is important to maintain adequate breast supply? Sufficient mammary tissue should be there, the hormone levels should be normal, and there should be regular, effective removal of milk. So what are the problems? When do we see lactation insufficiency? When there's no proper breast tissue, it can be in hypoplastic breast, or if the patient has undergone any previous breast surgery. And abnormal hormone levels are seen if there's any retained placenta. Then because of that, because of the retained placenta, the progesterone levels don't come down and then prolactin doesn't increase. So there's no proper breast milk production. So it is also seen in severe PPH, hypothyroidism, and increased stress and anxiety. Also, milk ejection. We should make sure that the patients are counseled to empty their breast completely, which is very important. The method and frequency of milk expression is important. Latching difficulties should be sorted out. And when the patient uses infant formula and they introduce solids early, then also the breast milk supply decreases. So now coming to pharmacological galactagogues, these are the pharmacological galactagogues we are going to discuss: domperidone, metoclopramide, sulfuride, growth hormone, recombinant human prolactin, thyrotropin releasing hormone, oxytocin, and metformin. So these galactagogues mainly act on the pathway. Domperidone, metoclopramide, and sulfuride act by inhibiting the dopamine. And growth hormone and prolactin, they increase the milk synthesis. They are synergistic with the prolactin action. Oxytocin, the oxytocin nasal spray, it helps in milk ejection. So now we'll discuss one by one. Domperidone is a dopamine antagonist and it increases serum prolactin. It is actually used as an antiemetic and prokinetic. Many studies have been done. Domperidone is one drug on which many studies have been done for its use of galactagogue. So these are all the studies that have been done. Most of the studies have been done in preterm infants, and there are 2 or 3 studies done on term infants. It was found in all these studies, 10 mg twice a day was used for a period of 5 to 28 days, and it was found that average increase of 88 ml per day was found on using domperidone for when 10 mg twice a day was used for 5 days. It had a lot of maternal adverse effects, headaches, dry mouth, and GI disturbances were seen. The main controversy arose when they found that it can prolong the QT interval. So it has a risk of causing ventricular arrhythmias. So there was a study done where it was found that a mother who had a prior history of ventricular arrhythmia we have to be very careful and we should avoid domperidone in such patients. Otherwise, it is okay to use it for a short period of time. So these are the studies, as I said, a lot of studies were done on preterm infants, which was found to be a bit beneficial. On term infants, there were less studies done. Coming to metoclopramide, it is also a dopamine antagonist, and it increases serum prolactin. So the studies for metoclopramide were done on term infants. Here also the dose was 10 mg thrice a day. It was used for a duration of 5 to 21 days. There was very moderate increase in breast milk supply. On using, as you can see, the first study, increased doses were used, and it was found that when you use higher dose, there was a moderately more increase of breast milk. While so the increase in breast milk supply was similar to domperidone, basically. The main disadvantage in metoclopramide is that it can cross the blood-brain barrier. So it has the potential to interrupt dopamine signaling in newborn. It can have CNS effects in the mother, like increasing the risk of depression. Already the mothers are in postpartum depression, so it can add to it. And extrapyramidal side effects are seen, like tardive dyskinesia. And it is better to use it for a short duration, like for 5 days, 10 mg twice a day for 5 days. Also, metoclopramide is less desirable than domperidone as a galactagogue because of the adverse effects. So when we compare domperidone and metoclopramide, there were studies done by Blanketar and engorgement. When we compared both, it was seen that the difference in increase in production was not very different. Blanketal found that 35 ml per day was the difference, and engorgement between the two, it was 31 ml per day. So both have the same action. They are both dopamine antagonists, and the difference in milk supply increase in milk supply is also not much. But the main thing is that because the metoclopramide crosses the blood-brain barrier, domperidone is more preferable. So these are the two drugs, domperidone and metoclopramide, which have more studies and they are found more favorable. The others are not very useful. So sulfuride also has a dopamine antagonist action. The studies found that there was considerable increase in milk production, but because of the adverse effects, it is not used much. So it was found that infant exposure through breast milk is up to 20% of the maternal weight adjusted dose, which is more than other galactagogues. So the safety is, so more studies are required to see if it is useful. These are the studies which were done, and there was considerable increase in breast milk production, but the adverse effects are more for sulfuride. Growth hormone also is released by anterior pituitary gland, acts synergistically to prolactin. Mechanism of action is not very clear. It increases the production by secretion of insulin-like growth factor. Even with growth hormone, 2 studies were done where the increase in milk production was not very significant, although maternal and infant side effects were not reported. But the main thing is that it has to be given subcutaneously. The mode of administration and the high cost of human growth hormone, this is the disadvantage. These are the challenges of human growth hormone administration, the high cost and the mode of administration is difficult. In recombinant human prolactin also, it is used to treat lactation insufficiency, that is the result of prolactin deficiency. So only one study has been done till now where the mothers of preterm infants were enrolled who have prolactin deficiency. So it was found that so in this study, there were 60 micrograms per kg was used twice a day and daily. It was found that when you give the dose twice a day, there was increase in milk supply. But again, high cost and administration challenges are there, so it is not used much. It can be used in very rare situations where domperidone is not suitable. Coming to thyrotropin releasing hormone, it acts on anti-pituitary to increase the serum prolactin concentration. These 2 studies show that there was not much change in the milk production with thyrotropin releasing hormone. So, but they found that in one of the studies, the increase in breast milk volume was accompanied by increase in basal prolactin levels in the TRH arm, but in placebo there was decrease in basal prolactin levels. So it did cause increase in prolactin levels, but the milk production was not very significant. In another study, it was found that 2 cases had maternal hypothyroidism, so the safety profile is not much for thyrotropism. So coming to oxytocin, it increases milk supply by, it regulates milk ejection. Oxytocin is actually used in immediate postpartum mothers to oxytocin nasal spray is given to cause milk ejection. That is about it, but we don't use oxytocin later ever. So there are no studies which have been done with the use of oxytocin in the setting of established lactation insufficiency. It is only used initially in the ward when the patient is there to, we give oxytocin nasal spray to cause milk ejection and increase the milk supply. So this study shows that there is not much difference with the use of oxytocin nasal spray also in producing breast milk. Coming to metformin, it acts as a galactagogue through its insulin sensitizing action, and it was found again. The study was done by Norman et al. And it was found that there was not much increase in the breast milk production with this. Metformin was given as 750 mg per day with gradation of doses till 2000 mg per day, but only 20% of the women showed any difference in breast milk supply. So this is a very interesting fact. In adopting mothers, also they are doing studies to start lactation. So this is called induced lactation. So some women who adopt children, they they occasionally request assistance in initiation of lactation. So successful breastfeeding can be achieved by injection of metoclopramide 10 mg thrice a day or chlorpromazine 25 mg thrice a day, along with vigorous nipple stimulation using a breast pump for every 3 to 4 hours. So this was found to start lactation, established lactation. This preparation should begin a month before the expected delivery is due. And once adequate lactation is established, the drug should be tapered. So mainly in women who have a baby growing in the surrogate, this can be started way earlier. How much it is effective is the studies still have to be done, but then this is one method which they are using for induction of lactation. So to summarize, I would like to say that the largest and strongest body of evidence supports the use of domperidone as a first-line medication for pharmacological management of lactation insufficiency. Because of its low cost, it is well tolerated, and there is moderate quality of evidence that it produces modest increase in breast milk supply in mothers of preterm infants. In term infants, there are not many studies. Another alternative for domperidone is metoclopramide in women where domperidone is not suitable. The rest of the galactagogues, there are not many studies, and because of their ineffectiveness, they are not used. So the only two galactagogues which are found to be useful are domperidone and metoclopramide, but also we have to educate them only after we have exhausted all the other non-pharmacological strategies. That is, firstly, as I mentioned in the beginning itself, we have to counsel the mother from antenatal. Like all the speakers have spoken before me, we have to counsel them from antenatal period regarding the latching and support them, encourage them to breastfeed, teach them how the teach them proper latch techniques and everything. And after that, we can use a short course of pharmacological galactagogues, but then we have to also watch for the adverse effects. So concluding, I would again like to say that domperidone is the most effective, but how much these galactagogues have effect on the micro and macronutrition composition of the breast milk is still to be studied. So thanks.
And GM Neurology from KEM Mumbai. He's joined us at KIMS Cuddles NICU Kondapur recently, around a month ago. He's someone who has worked in a unit where there was a huge milk bank. KEM boasts of one of the biggest milk banks in the country. And he even tells until today that one of the reasons he joined our unit is also because we also have a milk bank. So we'll listen to him about what his opinion is against the use of routine use of Galactagogues in breastfeeding mothers. And after that, we can have a rebuttal from Dr. Amrita if she has any points. If you want to contest against something that is being told, you can. And then we'll conclude and proceed to the panel.
Hello, good afternoon, everyone. So, after the so much of discussion on the various breastfeeding problems, and after the wonderful talk by Dr. Amrita regarding what are the galactagogues that has been used. So, to discuss against the galactagogues is a challenge. I really don't want, but still I have to do it because I have been opting. And anyway, it suits to my thought process also. So these are the various galactagogues that we are using nowadays. So one of the most important thing is domperidone. So majority of the discussion has been completed by Dr. Amrita. Is a dopamine receptor antagonistic which increases the prolactin release and is the most commonly used galactagogue in the world, right? So based upon the trend, in Australia nearly 100% NSUs are using domperidone as their first galactagogue. In Canada also, the 1/3 of the preterm mothers have been prescribed domperidone and the prescribing rates has been increasing. And in England, nearly 3.8 times the prescription of domperidone has been increased. So nowadays, majority of the centers are using domperidone for the galactagogue. As already told, the domperidone is not only having the advantage, there are certain disadvantages. The mild can be headache, dry mouth and GI disturbances. And serious concerns are it can antagonize the potassium channels and can increase the QA interval. And this can lead to the arrhythmias, torsion is depointed, resulting in ventricular fibrillation and sudden death. However, the studies have not found any major difference between the non-lactating and the lactating mode. The problem is that every mother may not respond to the domperidone. There is some treatment response variability is there. Nearly 1/3 of the mothers may not respond, especially the mothers who are high maternal BMI may not respond well to the domperidone. Also, the mothers who have initially high prolactin levels may not respond to the domperidone. But still, the domperidone is the most commonly used drug. But till now we didn't get any FDA approval for the use of the domperidone, but we are using off the label. And majority of the mothers are actually getting benefit with the domperidone. But one, we should be more concerned before using domperidone. So we don't need to prescribe domperidone each and every month. And the metoclopramide was similar to domperidone. Some studies have suggested that it is less efficacious than domperidone. But the problem is it can cross the CNS and can cause postpartum depression, anxiety, extrapyramidal side effects. And the FDA has been placing a black box warning on the drug. And there are so many studies that has been done on the metoclopramide. So we've seen that so many studies, and majority of the studies didn't give any benefit by using the metoclopramide in relation to the establishment of the breastfeeding, in relation to the mean weight gain in the infant, and the amount of the milk that has been produced by the mother. And there are certain herbal galactagogues like your fenugreek, menthe, shatavari, mahogany leaves, garlic, and ginger. So we are using so many galactagogues nowadays. We don't know the exact mechanism how they are functioning, but we are, as per our experience, we are getting a benefit. And also from the ages, we are being told that using all these herbal galactagogues will benefit the mother. Fenugreek, they found that the majority of the effect is because of it stimulate the sweat gland production. So the mammary gland in itself is a modified sweat gland. So by the stimulation, it can promote this thing. And is most commonly used along with the shatavari. The shatavari will increase the estrogen levels and that can lead to production of the milk. So these are all the theoretical mechanisms, but the studies have not been very favorable. And some studies that have been favorable are now very small studies. So we need not have a strong evidence till now. The problem is we are using all these galactagogues, especially the herbal galactagogues, the so-called label as safe drug, but I don't know whether they are really safe, because half of the time we don't know what is the mechanism. We only know the theoretical mechanism, and the study that has been done are very small studies with the inconsistency in the methodologies, and the dosage also wide variable. We don't have any fixed dosage. Every company will quote their own dosage, and because of small studies and wide variability in the participants, the interpretation of this result from the different countries to our countries is also not that valid. And what I personally feel is, sorry if someone agnostic me, it's more act as a placebo rather than true effect that is happening with this galactagogue. But anyway, we are getting any benefit psychological also, so prescription might not be a problem. The problem is we don't have a standard dosing preparation. So every company will quote different kind of a preparation. And we don't know what are the other contents that are available in this galactagogues, whether it's causing any other problem, and anything that can lead to the allergic potentials and drug interactions will affect the other medication that has been given to the mother. And the Academy of Breastfeeding Medicine will not support giving any Galactagogues. What they want to do is first we do the medical evaluation of the mother. We see how the mother is both psychologically, physically, whether she's eating adequate amount of food, taking good amount of water, whether she's mentally free, stress free, and she's free from all medical illness like hypertension, the diabetes is controlled. Then we need to check whether the placenta has been properly expelled. All these things we need to evaluate. Once that thing is there, the next most important thing, she should regularly express the milk either by breastfeeding the baby or by using the pumps or by self-expression, because lack of the milk expression will lead to the accumulation of the milk, from where there will be a hormone called as lactation inducing factor, which decrease the production of the prolactin. In this way, the delayed secretion of the milk and expression of the milk can lead to more amount of the lactation failure rather than the frequent expression. And the Galactagogues will not work if the mother is not expressing the milk properly. So in this way, the Academy of Breastfeeding Medicine issue the guidelines for the various Galactagogues and the breastfeeding thing were not very pro to the using the Domped and other Galactagogues. And there are certain studies, and even the Cochrane oral Galactagogue that was published in 2020 is not very favor of these things, and they are suggesting to have a large article with high quality evidence to support this natural Galactagogue. So my conclusion is Galactagogues can be helpful, but they might be associated with some significant risk factors, and more among non-pharmacological factors like they need to support the mother psychologically, emotionally, and physically, treat her diseases, and ask her to express more amount of the milk. Then if still the mothers are not able to express the milk, then we can prescribe the Galactagogues for a short duration of the time. And healthcare providers should give the adequate guidance to the mother so that she may not land up in any other problem. Thanks.
Thank you, Dr. Ramchi. So we have listened to both the versions, for use of Galactagogues, where Dr. Amrita showed us a lot of evidence about how the use of drugs like domperidone or metoclopramide have been shown to translate into a significant, it may be small, but a significant improvement in milk synthesis, which is also correct. But we also heard from Dr. Vamshi, and he began by telling it this is something that is close to his heart, because the use of a Galactagogue cannot replace the role of all of us as healthcare providers taking out time, explaining the importance of early initiation of feeding, early skin to skin, plenty of rooming in, and establishing adequate latch, which are probably much more or many times more effective than the use of drugs for improving lactation. So thank you both, Dr. Vamshi and Dr. Amrita. Any rebuttal points from you, Dr. Amrita?
I definitely agree that non-pharmacological, as I mentioned in my talk, non-pharmacological methods should be the first line, and we should always advocate. It begins with counseling, it begins with talking to the mother, and regarding every possible thing, giving her confidence, telling her to think about, not asking her not to listen to the mother-in-law, grandparents, and all, and completely focus on the child and herself. Give both of them time, privacy to improve bonding, and if you give them time, they will figure it out. The mother and the baby will figure out a way to um, bond and start breastfeeding. Of course, other problems like latching difficulties and the method and the technique should be explained, but they should be given their own time. And of course, Galactagogues can just be like a push, like as we have seen in the studies, I mentioned placebo and the drug arm, they don't have much difference. It is just a little push so that then they feel that the drug has done wonders, and then they get more confidence to continue. Because Galactagogues we can give only for a short period of time. We can't give them for a long time. So that it is just an initial push for them to carry on and maintain lactation for that long time, 6 months or 2 years, how much ever you want to see. So I would not say it is a boon, but it is just a push.
Yeah,
But we should not regularly advocate. It is only the last resort.
The problem is even if you don't advocate, the patient will, but the patient will not get satisfied. They will come again. We need to counsel them. As long as we need to try not to prescribing, but if
we should not give them an option. We should talk about everything else, and if they are very stubborn, then just give them
yes,
a
yes, definitely, I'm agree.
It very lively, it was not a debate. I think it was more like a discussion on the pros and cons of the approach. Thank you both, Dr. Amrita and Dr. Vamshi, for keeping it so enlightening. So we'll move on to the last session. We are already over the time limit for the day, but I promise you this will be the most interesting part of today's CME. We have a panel discussion which is to be moderated by Dr. R.S.V. Sri Krishna. I'm sure most of you know him very well. He needs no introduction. Dr. R.S.V. Sri Krishna is basically a pediatrician. He did his DRMP in pediatrics right from Hyderabad here. And then what makes him unique is his work with community pediatrics, with his extensive role as a UNICEF consultant, where he has interacted with lots of pediatricians, nurses across the country, working in the government SNCUs and also across private hospitals in the city. And today he's going to moderate this panel on breastfeeding practical challenges with a team of panelists whom I think he can introduce better.
Yes, thank you. Thank you, Dr. Aparna. Thank you, KIMS, for this opportunity. Greetings again, Geeta ma'am and the audience. Dr. Aparna always puts me in these scenarios where content is more, the time given to me is very less. That is not the challenge. The challenge is to make it enlightening and also entertaining. So it is now 4:15, 4:40, max will finish, 20-25 minutes, and I'll make sure all of you are engaged. That is the actual challenge. I invite on stage the panelists, Dr. Deepthi, Dr. Vamshi Krishna and Dr. Ramireddy. So Dr. Deepthi is the obstetrician, Dr. Vamshi, Dr. Ramireddy are pediatricians, Dr. Vinoda and Archana from the lactation side. And it's a very esteemed panel. And thank you all of you for sparing your time. And apologies at the outset, don't blame me, blame your own person for giving you very less time to answer questions. My part was done by making the question. Your part is to answer them very quickly. There are 10 steps to successful breastfeeding. There are many challenges. One of the challenges we just saw. The challenge was to whether to give finally Galactagogue or not. I am sure most of us are actually more confused now, isn't it? Now I wanted to ask Aparna, will you finally give or not? But then I thought I'm cutting my own time, so I won't ask that. So like this, there are more challenges in life. Unfortunately, breastfeeding has the maximum challenges. Fortunately, all of them have solutions. There are many things in life without a solution. This problem has a solution. Almost all of them. But it is our wisdom to find. So I have 10 challenges and 5 very good panelists who will tell me. And this is on the occasion of World Breastfeeding Week, where we talk about this. And the purpose is served because we're having the special CME where we're talking about breastfeeding and more so the challenges. We need to close the gap, and I'm sure we spoke about how we can close the gap, and this is exactly how we do it, by talking about it, talking about those aspects which matter the most, and also taking it into action. The first challenge to Dr. Deepthi, half the time our work should have been done by the obstetrician. And this work, if properly done, all the pediatrician will have to do is just smile, play with the newborn, and send back. One of the major challenges we face is the mother comes with sore nipples and inverted nipples and some of nipple related problems. So please tell us what are the common challenges and how do we solve them? We include you primarily.
Good afternoon, everyone. Coming to flat nipples, generally first we do a pinch test. When we pinch at the base of the nipple, if the nipple is protruding out, then it's a flat nipple. If it isn't, then it is called an inverted nipple or a distracted nipple. If it's a flat nipple, then we can just comfort the patient saying that the baby latches completely the areola breast, not the nipple. That mere counseling will be enough. And coming to the inverted nipple, as already the speakers have spoken, the K3 method and the nipple pullers, all these things will help you out. The K3 method actually is a little painful. Nipple pullers which are available in the market, they are comforting more than that K3 method. Coming to sore nipples, it's better if we teach them prior how to latch the nipples rather than when they come with sore nipples. So proper technique of latching will help them out. That's it. And some lanolin creams, all those may also help. But rather than that, proper techniques would be of great help.
Thank you. Thank you. The next question is for Dr. Vinoda. Another problem which perhaps the mother should have been informed well in advance is that she will get milk. And this milk, if we do not handle the breast properly and the mother properly, will lead to more problems. Not getting milk itself is one issue. Getting milk and not handling it well is the other issue, wherein you will have breast engorgement and sometimes breast abscess. One, how does the mother detect it? Are both of them same? Third, how do you solve this challenge?
So basically, mothers need to be informed that engorgement is a normal phase, but that the engorgement is mild or severe is what is most important. Mother should be advised that continuous feeding to the baby is very important, even if the baby is sleeping. Most of the times, mothers tend to, reach to the baby only if the baby is crying. So mothers have to check on the baby. They say demand feeding, but if the baby is waking up before 2 hours, then it is demand feeding. And otherwise, we would recommend the mothers to make an attempt to wake up the baby by undressing and putting a little finger into the mouth, by doing finger sucking for the baby, and then let the breastfeeding happen more frequently. Sometimes the duration of the feed is very less, so we recommend the mothers that it should be at least for half an hour. Most of the times babies tend to sleep off at the breast. That is also to be discouraged. And the number of feeds overall should be at least 8 to 10 minimum. So these are the things, and mother should be informed that there should not be any nipple pain. If there is nipple pain, that means it is improper latch, and we should inform the mother that either giving formula or expressing milk and giving or any other method, and the feeding is not happening well, as I mentioned, then there would be chances of engorgement. So again, engorgement, how to treat the engorgement? Firstly, the mother is going to have a lot of pain if it is severe. If it is mild, she can handle it. If she is knowledgeable, she can handle it. And if the family is educated well enough, then she can handle it better. I think the father should be more educated how to help the mothers regarding, this. If he can also help with the massages and remind her how to do the breast engorgement massages, like previously in the sessions it was discussed. And reverse pressure softening is one of the techniques that can be followed, and that really helps the milk to go away from the nipple and the areola, and it helps in better latch. Ultimately, if the baby is latching well, usually engorgement means the breast is going to become hard like a rock. So baby can't latch onto a rock. So first thing is to soften this breast, and then baby latches on, then the engorgement release. If it is not happening, mother should be advised regarding how this engorged breast looks like. If it is severe, it is going to become warm, it is shiny, and if the mom thinks that she needs to put a hot compress in that shiny, firm breast, it's going to give a burn on her breast. I have seen a lot of cases where mothers have actually applied hot fermentation, and it has led to superficial burns, and which is to be avoided. And then mothers can be advised regarding pumping, hand expressing, and then feeding that to the baby, and avoid formula as much as needed.
Thank you. So we have seen 4 problems that have a solution. Inverted nipples, sore nipples, breast engorgement, breast abscess, all these are problems, challenges that the mother faces. All of them have very simple solutions. Another challenge which the country is facing, the whole world is facing, and we are not able to find out why. Every mother is dictated by the hormonal changes that happen. Every mother, ideally, should be able to breastfeed soon after birth. It is a natural thing. But still, if we see over years, over decades, this graph has not shown improvement. At the max, it has reached in NFHS 5 up to 41.8. Early initiation of breastfeeding. We keep talking, but still less than 50% are having early initiation of breastfeeding. So, Dr. Vamshi, what is the challenge and what can we do about this?
The problem with the early initiation of lack of awareness in the mothers. So we need to have a proper antenatal counseling where we need to explain the mother what is the breastfeeding, what are the advantages of the breastfeeding, and what kind of the milk they will get initially in first 48 hours. They will get only colostrum. Subsequently, they will get the matured milk. All these things should be told in a proper way. So improvement in the knowledge and creating the awareness is one of the first steps to be done for the child. The next is they should get a complete support from the family and the husband, and they should be given prior importance in the by giving proper amount of rest, food, water, milk, everything. So what we have been routinely heard in our is the mothers have been not giving any good amount of food, the things that they like. They have been always starved. So both in Telugu state they usually call it like patyalu. So they don't give the adequate amount of the food. So So majority of the times, however we counsel the mothers and mother-in-laws and mothers, their own mothers, they still they say the same thing. So by giving the milk, the baby will get jaundice. By giving this amount of this kind of food, the baby will not get digested. So all these things are the parents that need to be explained to them clearly from the antenatal from antenatal only, and we need to prepare the mother and the family so that the breastfeeding should be in a proper way. The third part is majority of them nowadays are working mothers, so they don't have that amount of time and the time, and also they don't have energy to give the breastfeeding, and so many regulations need to be done in order to provide the adequate amount of maternity leave so that they can have a good amount of breastfeeding.
Yeah, so I think the onus is on us. It's not just the mother. I think we need to convince that this is similar to the most wonderful drug ever in the world. Never do we convince so emphatically. Never do we motivate the mother so much. But then we are all healthy now only because someone else has done it for our mothers, and that is why we are doctors. Again, comes back to the point that you breastfeed your baby will become doctors, your baby will excel in whichever domain they choose. I think we need to find the right words that will motivate. Good for health, benefits, ఇవన్నీ చెప్తే వినరు, అర్థం కాదు, కన్విన్స్ కాదు. We need to find innovative ways in which we drive home the same point, and they become the ambassadors of breastfeeding, not just that we keep shouting the same point. I think that's very important.
The funny thing is, the own mothers will say that మా అమ్మాయి అలసిపోతుంది, so that ఒక ఫీడ్ ఇస్తే ఏమైపోతుంది ఫార్ములా.
Yes, so
most common dialogue that you have heard.
Yes, one major point for obstetricians. Next time, first trimester, if a mother comes, next visit ask their mother to come. Very, very important. That is what? This mother with her mother and also mother-in-law. And please have separate session for them. ఇవన్నీ మనకు అనుకుంటాం ఏముంది దీనిలో ఊరికే what will it do? It will improve this static graphic. Because all the time it is us trying to find innovative ways of medicine and ventilation, but forget that there are simple things that will change. So the next time request the KIMS department at least, please call the mothers for the second visit or the third visit. Trust me, the work of Aparna will become much easier and the survival also will be much better. So now we come to another common challenge. So again, that was another challenge, more of a social challenge, but something that is doable. You have to think out of the box. You have to think that is my sister, that is my cousin. Then you will probably come up with innovative ways in which you can counsel them and then convince them. Dr. Ram Reddy, these are purely medical problems, cleft lip, cleft palate and hypotonic infant. Trust me, there's a very small number of babies who have these, but even this has a solution. What is the challenge and what's the solution?
The cleft lip problem is there is a split in the lips, and the cleft palate is there is communication between oral cavity and nasal cavity. So normally if the baby has to exert negative pressure during suction of the breast milk, so baby needs that lips from the anterior part of the oral cavity, and also needs oropharyngeal muscles and soft palate to close the oral cavity from the posterior. So baby needs these lips and oropharyngeal soft palate to exert the negative pressure. So in cleft lip, so normally most of the babies will start immediately breastfeeding because these cleft lip, most of the babies will good enough to exert the negative pressure. But the problem with cleft palate is where there is a clear communication between oral cavity and nasal cavity, and where the babies will not able to exert that negative pressure, and also because of that they are not able to suck because of this poor sucking. There might be poor weight gain and also nutrition deficit. So in cleft lip there will be some strategies where there is a position called cross-cradle position and also football position, where these positions works better in cleft lip babies. And also semi-upright position, this position works in both cleft lip and cleft palate, where the mother will hold the baby with chin support and will exert that, will help that baby to exact position to make the mother will support the baby to exert the negative pressure. In cleft palate, the major problem is because of the clear communication, because of the less negative pressure, the problem is here the baby not able to suck good enough. So the problem is, so here the mother has to support the baby, keeping the major segment of the breast into the unaffected part of the cavity, so that baby able to exert the negative pressure. If the open communication is very large enough, then mother has to keep the breast, a major segment of the breast in the downward position. So normally post surgery in most of the cleft lip, surgeons will start feeding immediately after the surgery of cleft lip. But in cleft palate, most of the surgeons will start feeding after 1 day of the surgery. And in hypotonia muscle, as we discussed earlier, because there is a poor tone in the muscle, because of the oropharyngeal muscle tone, so baby is not able to again suck the breast. So here we'll use dancer hand position with third to fifth fingers will be rolled under the breast, and index finger, thumb finger will be hold the baby's chin. So baby will be kept straightly onto the breast so that baby can exit the sucking. But if at all baby is very poor enough or very not able to suck, where we can go for direct, what we say, we can go for cup feeding or spoon feeding, or we can also go for orogastric feeding. But in hypotonia, we need KMC, kangaroo mother care, because sometimes because baby is staying in the NICS for longer time, where the mother separated from the baby, and mother can't be enough to express the breast milk. So here we need KMC, kangaroo mother care, where skin to skin care will be kept, so that mother will be enough to keep the milk flowing. But when we are shifting the baby from NIC to direct breastfeeding, or when we are directly going from the orogastric feeding to direct breastfeeding, at least mother able to produce 500 ml in a day. That is the minimum criteria to shift the baby to direct breastfeeding.
Thank you, Dr. Antenatal. So he spoke about kangaroo mother care and one place where it is a treatment option. Kangaroo mother care is not keeping baby mother and mother together. It is treatment. It is like that dolo that you take for fever. It cures, it saves, it protects. Kangaroo mother care is treatment. And then one place where it is used as a treatment majority of the times is in prematurity. So they have issues in breastfeeding. So Dr. Vamshi, what are the challenges very briefly? In prematurity, do you still want them to get mother's milk? If so, how do you solve this challenge?
So especially every baby should get the mother's own milk, and the premature baby should get their mother's own milk in many, so many advantages are there. So they cannot have that breastfeeding directly because of the prematurity, because of the low birth weight. So they need to be given the gavage feeds initially, then they can be transitioned to the spoon feeds, and then they can be started on the breastfeeds at the earliest opportunity. So the mother's own milk should be provided at every point of time. Sometimes if the mothers are not able to provide their own milk because of any medical issues or because of some other logistic issues, then the next option is the donor human milk. So here the milk banks plays an important role. That's why all the units where they want to cater the extremely low birth weight baby should have a milk bank like us, so that we can have a good amount of feeding tolerance in the babies. And the second thing is, mothers should be involved in the training of their feeding of the baby, so that can lead to the early oral feeding and early breastfeeding. This can lead to the sustained breastfeeding rate.
Thank you. So we finished 5 challenges as promised. It is just halfway. I have another 10 minutes to take up the other 5, which are more interesting challenge. Ms. Archana, the challenge for majority of the mothers is on day 1, day 2, what do they see? Few drops. What is their expectation? Flow. Lot of milk. That is what is their perception. So the first thing they will ask you is, not ask you, convince you, is that they don't have enough milk. First of all, what are the criteria? And I said that it is a hormonal change. It will happen. If you switch on that light will come. Same way, as soon as the baby is separated from the mother by the cutting the placenta, the hormonal changes start, and we know it. So is there any challenge for the mother? And secondly, how do you convince the mother whether she has adequate milk or not?
So, as Dr. Said that it is most of the time it is perceived than actual low milk supply, I would say. So, how do you convince the mother she's producing adequate? First thing, saying her about the stomach size of the baby. The stomach is very small. The baby requires just 4 to 5 ml of milk per session, per feeding session, I would say. And looking at the wet diapers of the baby, and also looking at the weight loss. So these are the things which you should look into. Other than that, most of the mothers would always, before feeding, express and see there is nothing coming out. I don't see a drop of milk. Chukka kuda vastaledu. Or sometimes they also say that it is water. They don't understand it is cholesterol and not yellow color or light color milk, whatever it is coming. They say that నీళ్ళు వస్తున్నాయి అంతే, there is water coming, there is no milk. Milk, matlab, they only think it is white. So that is also one more, actually, we need to handle that also. So I would always say that whatever is coming from your breast is the liquid gold that is to be given to the baby. You cannot say that is something else. And second thing, whatever is coming is more than enough for your baby, because that is how the body is made for. That is how we are made for. So, and coming to another challenge what we face later on after going home, I think before discharge we have to educate the mother whether she should not doubt her supply. If the good latch and attachment and position has been established during the hospital stay, then she should not worry about her production. She should always rely on the wet diaper, stool passing, and weight gain. These are the only three things she should be concerned, not about crying, frequent feeding, or anything else. As
Thank you. Thank you. Yes. Yes. See, cry is the language of the baby. You can't say cry is for feed. Then the mother will feel I'm just born for this. 1 year of my life, the only work I have to do is feed, feed, feed. My back aches. I don't have sleep. I have constant headaches. And she'll feel motherhood was like this. So you'll have to tell her first that cry is only language. The way I'm talking to you, it doesn't mean I'm hungry. So same way, it is just a language. Second point, if there is adequate input, then there'll be adequate output. Someone has to look into this. So if you have a bank account, then you will see bank balance. But how will you measure what is inside the breast? You can't measure. The best way to measure is how much urine the baby gets. Where from that urine would have come? If nothing was going in, how will output come? Unless there is input, how can you get output? So this is the most important criteria. Everything else, talk after you count the number of times the baby has passed urine. I'm sure this will help. I think the next part, yeah. So Dr. Deepthi, half of the time we feel mothers cannot breastfeed after C-section. Let me loudly say, every mother can breastfeed after C-section. We doctors are not able to do it. You are not putting your best efforts to make the mother breastfeed. It is our flaw, our mistake. So please dispel this myth for us and tell us what challenge actually mother will face. I know that she has anesthesia, but she's still there. And as I said, once you have cut the cord, hormonal changes are all on and she can breastfeed. So what is the challenge? What is the solution?
Sir, most of the times, as you said, it's anesthesia, but most of the times it's spinal only, sir. We are starting in the theater itself as soon as we deliver the baby. Even this initiative was taken at King Koti Hospital along with UNICEF. They took one small stamp whether it is being initiated in the theater itself or not. That was working wonders actually. And even at from long, I have been associated with Dr. Aparna. We have been doing this from past 7 years. So we are starting in the theater itself. And that is gaining more confidence and it's easy also. And as you said, the little pain and all that is there. The position, the football position or rugby position, whatever, that is helping out. So
now, one question mother will ask is why all this when I'm in that dazed out state? Can I do it after 3 hours in the room? Why you want me to do in the OT? I'll do in the room.
No, we are counseling them prior, so these questions are not being raised in the theater.
Yeah.
So prior counseling is being given. Even apart from breastfeeding being initiated early, we have other advantages also, like oxytocin is being released, so our uterus contracts well, PPH is less. All these things we can explain prior, so that most of the time no one is like non-cooperating. 99% of the time they are.
I think, as you said, I think you have a very good team at KIMS, so they are able to convince mothers. One major benefit for the mother, what she spoke about oxytocin, once it starts, it makes the mother and the obstetricians work easy.
And, one greater benefit than this, sir, actually. We are pregnant, we are delivering like once we are mother and all that, and that baby goes to father. Once we have that skin contact, as soon as they are born, they have more attachment and bonding with us rather than the father. So even we are.
This point I can't refuse, and none of the male members will say anything now. Yes. And another major, yeah.
All the kids are attached to their dads in spite of all our efforts. So,
madam, male gender are showing more affection nowadays. That is it. Another major issue is the baby dozes off, isn't it? After, if the initial feeding, if it doesn't happen on the labor table, not even labor room, labor table, akkade se aale. If it doesn't happen, one, this oxytocin doesn't kick in. Second, the baby dozes off.
Yes, sir. It's
So,
like a demand supply thing.
4-5 hours delay అయిపోతుంది. Then initiating it becomes a headache. That is why you are seeing only 40% because it's our failure. So I think the commitment is needed from our end, and this is one of the very simple solutions. My talk was on challenges. Big challenge. Half of the mothers don't breastfeed. Simple solution. Okka chinna stamp. We spent 85 rupees for this stamp. This was UNICEF's idea, where we implemented this, convinced the commissioner. They were asking us budget. I said 85 rupees you give us, sir. We will start this. And once we started, we saw huge response. The trick was the one in the postnatal ward should not accept mother without case sheet. Case sheet should have the stamp. సో కేస్ షీట్ స్టాంప్ ఉండాలంటే ఆ నర్స్ స్టాంప్ వేయాలంటే చేయాలి కదా. అండ్ దెన్ వీ హ్యావ్ అ సూపర్వైజరీ మెకానిజం. ఐ వాస్ టోల్డ్ టు గో అండ్ సూపర్వైజ్ వెదర్ దే ఆర్ స్టిల్ డూయింగ్ ఇట్ అండ్ దెన్ పుట్టింగ్ ద స్టాంప్. ఇన్ షార్ట్, ద బ్రెస్ట్ ఫీడింగ్ రేట్స్ విచ్ వర్ 36% in the hospital jumped up to 89%, all with just one simple solution. This is also published on the UNICEF's country web page and is also available at New York office as one of the country's best practices. Some challenges are big, but the solution is very small. All it requires is just your determination and effort. Another one similar to this is the working mothers. All of you are here. You are also working mother. Now, how do you solve this problem where the mother comes and says, I have to go back to work and you told me to breastfeed every 2-3 hours. I can't come back soon. So how do I solve it? Give me 3 suggestions for the working mother, and many of them around this area are working in the IT field. So they need to focus on their work. Of course, also to your own staff here.
This is antenatal counseling, and mother needs to approach lactation consultant and discuss that she is going back to work very soon. And we have to encourage the mother to ask for maternity leave. Most of the IT companies, they are providing proper maternity leave, and they are even providing crush, and they are even providing work from home and frequent breaks between work. All this will definitely help. But mothers, when they are using breast pump to maintain their supply, when they are going to office without the baby, for them, they see that whenever they pump, the milk is not filling up the bottle, so they quit on pumping. They think that fuller breast, and then if I get a full bottle of milk, then only I am producing milk. But what they need to know is, they need to stimulate the breast more frequently and not bother how much they are producing. How much they are producing at each interval might be different, but they should not worry about that and frequently stimulate the breast. And I've been in this field from past 2 decades, and I have observed that from the IT companies, most of the mothers are doing very well, but in the medical field, the doctors are having to attend the hospitals. They don't have the choice of work from home, and it is very challenging to continue, feeding the baby. And so I think something should be done.
Yeah, so KIMS should engage more working mothers, at the same time increase the workforce. అదే కదా మీరు అంటున్నారు?
We need to bring in acts in every field. This is one of the field where we can't have work from home, definitely.
Yeah, in fact, I am reminded of the quote, mother herself, by the nature of being a mother, is a full-time employee. Whatever work she does at the office is an extra work. We do one work. Now, we ante manam, the male gender. We do only one work which is outside the house. Half of the time we don't do it inside the house also. So I think it's imperative on the organizations to have better work culture. It also sends a very positive message out in the community. For example, if KIMS Cuddles is supporting its own medical staff to breastfeed for 6 months, then the feeling of the public is that, oh, so they are a progressive hospital, they understand ethics, they understand medical concerns. So I'm sure when I go for delivery, I'll have a much better experience. So it adds to yours. Last 2 minutes, Archana, one major point which Geeta Garu raised was, mother ఒకటి చెప్తుంది, అత్తగారు ఇంకొకటి చెప్తుంది. First of all, this itself is a big challenge. Of all the clinical challenges I put, this is a non-clinical challenge. Where from do you get information? There is so much of information that it now becomes a challenge for you on which one to trust. So how do you handle this challenge of excess information?
So mainly, first is self-efficacy of the mother. So it is better that we educate the mother in the hospital before discharge about most of the things what she is going to face, so that gives her more of confidence. and giving her the actual resources where there are credible sources of information. Like we have a lot of social media platforms where credible information has been given, and also we should have a helpline number for lactation. I believe in that, at least an email ID or a WhatsApp number or something, where if any problem the mother is facing, she can just message, and we can give her the credible source. And peer to peer, mother to mother groups, mother to mother support groups also plays a very, very important role in giving correct information to all the mothers. First, another important thing is that listening to that mother and emphasizing what is her problem, and giving her a right solution or a right path where she will get the solution is very, very important.
Thank you. Thank you. And the last challenge is for Dr. Aparna. Dr. Aparna, breastfeeding gets zero income. Whatever you do, you will only tell successfully the mother will breastfeed. So frankly speaking, it is zero income for the hospital. It is investment in your time, which is very, very precious. You would have seen another 2-3 OP in that time. So what are the challenges that you perceive? And I'm not talking of KIMS. KIMS is a very good place. I'm talking about in general. What are the challenges that a director of the institute faces when you want to improve the breastfeeding friendliness of the hospital?
So that's a very, very important question. I think, so this is not just about you yourself, but it is about the whole team. So starting from the obstetrician, starting from the labor room nurses, the anesthesiologists, the postnatal ward nurses, your team of pediatricians, your team of nurses in the NICU, everyone should be convinced, and everyone should have absolute sort of passion for promoting this cause. That is the only way that this is going to become successful. So this starts from believing in this ourselves, and then making sure the entire team is with us on the same page, without any confusion, without any mindless of conflicts, because that becomes confusing to the patient. So the a lot of practices which are found to be scientifically sound, like antenatal steroids, do not really translate into practice that easily, and the reasons are actually quite simplistic. Either there is a lack of conviction, there is a lack of confidence, there is a fear of side effects, or there may be a lack of awareness, practical challenges, feasibility issues. So it boils down to trying to sit down and understand where the challenges are. And from this understanding will come the PDSA cycles of changes, which we can try and implement one by one to kind of translate into action. So, for example, the stamp that Dr. Sri Krishna told, which worked in one of the units, where every baby and mother dyad shifted out of labor room should have the stamp, whether early initiation of breastfeeding was done within 60 minutes. If it is sick, yes, then fine. If no, then the labor room nurse or the in charge nurse is forced to write an answer or a reason or a justification why it did not happen. So automatically, the more number of times they start writing it, they start thinking why this was not possible, and automatically the implementation of the intervention gets better. The other thing is to try and kind of get accreditation. For example, now we have NLF accreditation for all NICUs. So you have different levels of accreditation, level 1, 2, 3, 4. Now, one of the important objectives of getting this accreditation, of course, is to certify the unit as a level 3 or level 4 unit, and then it gives us ability to run teaching programs. But in the process of getting accreditation done, we realize what are all the lacunae in our system. We go through the checklist. So we go through the infrastructural needs, we go through the manpower needs, the processes needs, and then it becomes an important reason for us to rectify all these gaps. Accreditation becomes the second process. Likewise, the BPNAs come up with a accreditation for baby-friendly hospitals, wherein they have their own checklist and processes and systems checks. So it's a good idea for as many hospitals to go for this accreditation, and our lactation consultants have been talking to us about getting this done on priority, and we have started implementing some of these processes. So going for such accreditations automatically sensitizes our team to closing all the gaps.
Thank you, Dr. Aparna. I think the first challenge is to accept that it's a challenge. Accept that this is something important and that it needs work. Second, you need to work as a team. And I'm very fortunate that we took on this challenge of BPNI accreditation. When we first approached the commissioner and said accreditation, he asked, Babu, this is not corporate hospital, this is government hospital. Accreditation అంటే పెద్ద సర్టిఫికేట్ ఇస్తారు. ఆ సర్టిఫికేట్ కి వాల్యూ ఉంటుంది. గవర్నమెంట్ హాస్పిటల్ ఎట్లా తెస్తాం? Do you see Nilofer? How many babies come? How will you do? But sir, that is what I said. Challenge ante manam first accept cheyali adi challenge ani. Then you start working on it. And this is a picture I love. These are two extremely simple, sincere people who are working in the government. Dr. Alimelu has taken up that big task of getting accreditation for her unit and has achieved it. And Dr. Keshavlu is an ambassador for breastfeeding. So we took their help, and very proud to say that MCH Banswada in Telangana is the first breastfeeding government hospital in the whole country. We made this as a path breaker. Not many know, but this is a achievement for the state of Telangana. And Telangana now boasts of the highest number of breastfeeding friendly accredited hospitals. The way forward is to consider a challenge. Challenges is what makes life interesting, but overcoming them is what makes life meaningful. And I'm very fortunate and privileged. I had the privilege of getting that done. And thank you, KIMS. Thank you all for patient listening. I hope I finished it in time and also kept you all enlightened and entertained. Over to you, Aparna.
Thank you, Dr. Sri Krishna, and all the panelists for this very enlightening and interesting discussion. We have reached the end of the session, and it's time now to thank all the participants for the day who have stayed with unabated interest right from the beginning till the end. We were joined by some very senior pediatricians and obstetricians during the course of the day. I'm sorry I could not call out to some of them during the sessions. We have Dr. Madan Mohan sir from Hope Children's Hospital who joined us today. Dr. Gopi could join us from the pediatric community of Kukatpalli. And we have a lot of obstetricians who have joined us. I think some of them had to also leave for want of time. Dr. Rajeshwari ma'am, Rajalakshmi ma'am, I think Dr. Madhavi ma'am was there, Dr. Nagajayanti ma'am. Dr. Nagajayanti ma'am. I'm sorry if I'm missing out on anybody else. And of course, we had a lot of young, dynamic obstetricians who also joined us as speakers. Thank you, Dr. Amrita, Dr. Lakshmi Durga, Dr. Ankita, all of you. I think for obstetricians, particularly taking out time preparing slides must have been a very, very difficult and daunting task. I really acknowledge and congratulate all of you on this task for taking out your time and preparing slides, reading up evidence. It was wonderful having all of you here. I hope together as a team, in the coming years, we demystify a lot of these myths that are associated with breastfeeding and empower more and more mothers to successfully and to exclusively breastfeed their babies till 6 months. And last but not the least, we thank our Chief Guest of Honor, Geeta Bhaskar ma'am, who has taken out her valuable time. I actually thought she's going to stay with us for only around half an hour. But she actually stayed from the beginning right till the end of the CME, listening carefully like any of the other pediatric and obstetric doctors would have done. I think only thing she didn't do was to take notes, but she was listening to all of us so carefully. Thank you, ma'am, for adding this extra value to today's CME, and that really took that additional step towards taking it an extra mile and increase its reach. And I thank the organizing team from KIMS, as usual, Dr. Rohini and her team, Kiran, Kamal, and the marketing team, and Mr. Shrikant, all of you for putting up the show so nicely together, and Zydus for their sponsorship. Thank you, IIT TCB, for always involving us in these wonderful activities and giving us that, push for making time, space, and, reaching out for academic events such as this. Thank you, Dr.
Request all of you to please come for a group picture. Just one group picture and then we all can leave at the same time.